morning.
Good morning, Ma.
How are you and your family?
Good morning, Ma. Can you hear me?
I can hear you. How are you and your family?
We are very fine, Ma. Thank you, Ma.
Thank you for accepting to facilitate. We are very grateful.
Thank you, Ma. My pleasure, Ma. Thank you very much for giving me the opportunity as well.
Good morning, everyone. Welcome. You are welcome to the MWAN CME, Medical Women Association National Secretariat CME on medical laboratory procedures. We are going to wait for a few more people to join us and we are going to start. You are all welcome. I hope you can hear me.
Yes, we are hearing you very well.
Welcome, everyone. Welcome. Thank you, Izine. You are welcome. We are going to start very soon. It's 10 a.m. prompt now. And we are going to start, but we do not have a lot of time. Some of our speakers are on a schedule, and I would not like to keep them waiting. So I'm going to start straight away.
Can we wait for a few more participants? Please, let's wait for a few more participants. Let's wait for like 10 minutes. If we don't, I'm sure they will oblige us. We can take it from the question and answer session.
Welcome, everyone. We are going to start with.
Please, can we wait for 10 minutes? Dr. Nadim, let's wait for 10 minutes, please. 10 minutes.
So we wait. We are going to wait for some more people to join us. We have 15 people here now. We want more people to join us. I've sent in reminders, and we'll be waiting for more people to join us. You are all welcome. Welcome, everyone. Welcome.
Thank you.
Hello. Is my volume better now? Welcome, everyone. We are going to start very soon. Please, when you come in, meet yourself.
Can you assist with Dr. Nordin? Can you assist with admitting? Are you not okay? You've not been made a host. Let me make you a co-host. Please assist with the admitting.
Welcome, everyone. Welcome.
Okay.
Welcome. We're going to start in the next 2 minutes. Starting very soon. We want to give some more time for some participants to join us. We will start in the next 2 minutes. You are all welcome.
Thank you.
Welcome, everyone. Welcome. We are starting in 1 minute. We are going to start in 1 minute. So now we are going to start. We are ready to start now. Welcome everyone to the CME by the Medical Women Association of Nigeria. We This is actually going to be the last CME for the 2020, 2019, 2021 biennium. So we are going to start with a short prayer. In Jesus' name we pray. Well, I understand that some of us are Muslims, but we are serving one God. So we pray that this is going to be a successful CME. And as we apply our mind to what we are going to learn, it's going to stick and make us better practitioners. Thank you, Father, because we know you have answered. In Jesus' name we have prayed.
Amen.
I'm going to start with an opening remark. I'm going to introduce our president, the president of the Medical Women Association, Dr. Minimim Oseji. I'm going to give a few remarks. She's going to give us an opening remark, and she will tell us, she has something to say for us, but let me introduce her properly. She is Dr. Minimim Oseji, and a minute, please. Okay, some people are coming in, so we are going to admit them. Yes. Dr. Minimim Oseji is currently the national president of the Medical Women's Association of Nigeria. Please admit them as they are coming in. You can admit, you just press admit all. She is the national president of the Medical Women's Association of Nigeria. She's also the permanent secretary of the Delta State Ministry of Environment. She's the medical director of Baraka Community Clinic and a visiting lecturer with the Accra College of Medicine, Ghana. She's the executive director of the Public Health Impact Research Center, a research-based NGO which she founded in 2002. So without wasting much time, I'm going to welcome our national president to give us the opening remarks for this CME. Welcome.
Thank you very much, Dr. Onodim, our versatile ICT coordinator and the coordinator for this CME. Dear esteemed colleagues, the Medical Women's Association of Nigeria, MWAN, of which I am the national president for the next 13 days, MWAN is extremely delighted to welcome you to this continuous medical education program, CME program on laboratory medicine procedures, specifically targeted at medical doctors. The objective of this program is to promote the practice of conducting laboratory procedures, many of which can be done in the side laboratories which are attached to our wards or clinics, which ultimately will speed up the process of diagnosing several disease conditions, thereby improving the quality of health care delivery. Furthermore, being familiar with these laboratory procedures is a requisite for the practical component of Part 1 exams across several faculties of our postgraduate medical college. The skills we are going to imbibe today will also be useful during the organization of numerous medical outreaches that many medical associations have been known for. I join all participants to make sure they optimize the benefits of this training by volunteering regularly to participate in medical outreaches as well as the skills that they will imbibe. I sincerely thank the facilitators for their contribution to making today a reality. Thank you all and God bless. I am Dr. Mini Oseji, MWAN National President.
Thank you very much. I'm now going to introduce our first speaker. I'm going to tell us a bit about our speaker. Pastor Oledide, let me Let's make you the host so that you can share your screen. Okay. Okay, Dr. Elebute is our speaker, our first speaker. She's going to talk to us about she's going to take the first lecture on abnormal smears. She's going to talk to us about abnormal smears. And let me tell us a bit about our speaker. She is Dr. Modupe Elebute, MBBS, MD, and a fellow of the Royal College of Pathologists. After qualifying from the College of Medicine, University of Lagos in 1986, Dr. Elebute completed her postgraduate training in internal medicine and hemato-oncology at centers of excellence in London, including St. Bart's Hospital, St. George's Hospital, and the Royal Marsden. She received a prestigious fellowship from the Leukemia Research Fund and gained a medicine degree from the University of London for her groundbreaking work. UK, Dr. Elebute has held consultant and honorary senior lecturer posts at St. George's Hospital, the National Blood Service and King College Hospital, and has a well-established private practice at the Spire and Lister Hospitals in Nigeria. She has worked at the Lagoon Hospital, where she was instrumental in developing a pathology laboratory and a sickle cell clinic. Dr. Elebute is widely published in scientific journals and textbooks. She is passionate about giving back. She has helped to set up the Sickle Cell Club of Lagos while she was still at medical school. She is the patron of Build Africa and a past trustee of the Walkabout Foundation. Dr. Elebute has a passion for research. She has been the principal investigator for multiple center clinical trials, leader in novel monoclonal drug development work. She is widely published in scientific journals, and today, as I mentioned before, she's a fellow of the Royal College of Physicians. She's a fellow of the Royal College of Pathology. She's a member of the British Society of Hematology and of the American Society of Hematology. She's passionate about giving back, and I mentioned that she set up the Sickle Cell Club. She's a trustee of the Walkabout Foundation, and she's married with children. So I'm going to introduce Dr. Elebute to come on and give us her lecture. You are welcome, ma'am. Please let us welcome Dr. Elebute.
Good morning.
Welcome, ma'am.
Good morning. Good morning. Can you hear me?
Very well, ma'am.
Excellent. Good morning. And I honestly, I feel extremely honored, extremely privileged to be giving the first lecture on the Medical Women's Association of Nigeria's biennial CME program this morning. I have to say, when I got the program a few days ago and saw the eminent speakers on this, I thought, oh my gosh, I really have to step up my game. So thank you so very much for having me, for inviting me. I will just ask that everybody please mute their microphones as we begin, because there's been a lot of background noise. Thank you very much for that kind introduction too. Having said that, I think that my CV has moved in a slightly different direction since I think what was sent. Yeah, the host muted everybody, including me. Sorry about that. So I'm back in Nigeria. I started a hospital called the Marcel Ruth Cancer Center and Specialist Hospital in Victoria Island. And although, yes, I did a lot of pathology, a lot of laboratory medicine, I'm actually more of a clinician. So I'm hoping that my talk will enthuse a lot of you, because I'm going to be giving it with more of a clinical slant, especially seeing that the rest of the talks this morning are very laboratory based. And I think I'm giving by people who are more eminently qualified than myself to be talking about more laboratory work right now. So I'm just going to share my screen so that without much ado, we start just give me 1 second. I'm going to try and get it to, we got that in the middle. Okay. Just give me 1 second. I just need to open it in a way that I can. Okay, there we go. Perfect. There we go. I think I just had the header in the wrong place. Okay, so I was asked to, please, can you still hear me?
Yes, we can hear. Yes, we can hear you, ma'am.
Perfect.
We are muted, but we can hear you.
Yes, perfect, perfect. Okay, so my title given to me was abnormal blood results and blood smears. And I'm going to try very hard, as I said, to try and give you a practical session on, when we should be worried about blood results and when we should actually be getting the laboratory to make blood films for us. And I want to make one point right at the beginning, is that when we do need these blood films, we need them urgently, we need them on time. We also need to look at them so that we can use them to ensure that we impact the care of the patients that we're looking after. Because I think, it differs within academic departments, and I can see that the majority of other speakers are probably from that remit. In private practice, what I've found is that actually, there's quite a delay before these blood films are made, and certainly we should be making sure that we change that practice. So as I said, we became operational at Marcel Ruth in about November 2020, but have really just been fully operational for the last 7 to 8 months, where we are now seeing about 400 to 500 patients from all over the country. What we've tried to do is to develop what we call a one-stop shop. So the photograph now shows you the day unit for the chemotherapy patients and patients who need to be observed, or transfusions, infusions. We've got 2 modular theaters, which have been dedicated to my father's memory. We've got a lot of equipment for screening, imaging for screening. So our aim at the hospital is to cover everything from diagnostic and screening, and that's a 3D mammogram, right through to actually providing treatment for patients. And obviously the majority of the patients we see are cancer patients. So we're delivering chemotherapy, surgical oncology, as well as radiation therapy, because we have a linear accelerator on site. But for the purposes of today's talk, obviously we're focusing more on the laboratory, and we have quite a comprehensive laboratory at Marcel Ruth where we can do most of the tests that we need to do. And in particular, we can do things like tumor markers and virology, and particularly for treating our patients with chemotherapy, we can get a quick turnaround time in terms of not just full blood counts, but renal function, liver function, to assess toxicity. So far, we've seen, as I said, about 400 patients a month. What is interesting is that although about 80% of our work is cancer-based, we have quite a high ratio of hemato-oncology patients compared with solid tumors. When you look at cancer centers in most parts of the world, they only see about 7% of hemato-oncology patients, whilst we're seeing about twice that number. Now, I don't know whether that's to do with my background or just the fact that actually there are more hemato-oncology cases in the country than I would have thought there would be when we were setting up. But so, it's been really interesting for us, and we've had quite a few interesting cases to look after, and I'll share a few of those with you this morning. These are the types of diagnoses in patients that we've been looking after, from aplastic anemia or bone marrow failure syndromes, right through to, we've had about 3 or 4 acute myeloid leukemia patients. Again, I'm quite surprised that there's quite a significant number of these patients. And certainly we have quite a lot of patients with multiple myeloma with the aging population that we seem to now be having. So for the rest of this morning, what I'm going to try and discuss with you is what is normal? What are the normal blood values? What is normal hemopoiesis look like? And then, of course, to go into abnormal results and use that as a sort of backdrop to the big question of this morning's talk, which is when should a peripheral blood smear be made when it is important or it is useful to help manage the patients that we're looking after. So that this is a slide just to show normal hemopoiesis. Obviously, we all know the bone marrow is the factory that makes all our blood cells. And the pictures on the right show that in terms of the fact that obviously you have bone, but when we do a bone marrow, we look at the ratio of the cellularity to the fat spaces in the bone marrow. And as we get older, we have more fat spaces and less blood cells, which is why as we get older, we sometimes have abnormalities or a reduction in blood counts, which is just part of aging. Now, the development or the production of blood cells are regulated by cytokines, and in particular, erythropoietin and granulocyte colony stimulating factor, which are now available for us to actually administer to patients when they are lacking either red cells or white cells. So it's been a huge plus for us in terms of managing patients. For those of you who've never seen a bone marrow examination done, again, on the right-hand side, the patient lies on their side, and we access usually the posterior superior iliac spine to take the aspirate, but we also do a trophine. And this slide is quite old because obviously at the bottom now, we don't use metal needles anymore, thank goodness, because this test is actually quite uncomfortable. And I have to confess that the majority of the patients I do my bone marrows in, I do give sedation with midazolam. Now, when we look down the microscope, we start at the top of this slide looking at the primitive myeloid stem cell. Is a pluripotential stem cell, which can then divide into all the different cell lines that we then see later on in the peripheral blood, which we'll be discussing today. And of course, we're talking about red blood cells, erythrocytes, we're talking about white cells, and there's obviously a number of types of white cells that we have: neutrophils, basophils, eosinophils, lymphocytes, and then platelets, which obviously help us to stop bleeding. I think this slide was on the very first slide. So on the left-hand side, you've got an unstained but nicely spread peripheral blood smear, and on the right side, using one of the Romanowski stains, and different labs prefer different stains, and I honestly, it's not within my remit to even take you down that road. And I know that there are people who are talking later on who are experts at this, but we tend to use a right Giemsa stain. And that's what you see down the microscope for those of you, again, who are not necessarily laboratory based. And we're looking for a combination of red blood cells at high power, as in this slide. You would expect to see 2 to 5 white blood cells per high power field, and again, the adequate platelets on this film. And I'm not going to run through this. I mean, this is just, you should have a PDF of the slides, and I'm sure most of you know what the normal blood parameters should be. This is just as a backdrop to the talk. Now, I'm very delighted that Dr. Adewale will be speaking a bit later on. This is an excerpt from a combination of Barbara Bain, who taught me most of the laboratory hematology that I know out of Hammersmith Hospital, but again, a very, very good review by Dr. Adewale and colleague in the Annal of Ibadan Postgraduate Medical Journal, in 2014, which I think remains true today. And for those of you who want to switch off for the rest of the talk, I think if you just take this message with you, this is really the crux of it. When do we need to do a peripheral blood smear? And what are we looking for? And the biggest space that I think we tend to look at is abnormal blood results, when the blood results are either too low or whether they're too high. Typically, in most cases, we need to look at a blood film to try and find out what is going on. So what are the causes of these abnormal blood values that we're worried about? And to just keep you enthused, from dotted with it, illustrative peripheral blood films where they're either diagnostic for the condition or they're useful for what we intend them to be. So when you talk about a reduction in blood counts, obviously the biggest issue, and one that I spent quite a lot of my time doing work in, particularly with my doctorate in medicine, was working in a bone marrow failure syndrome department, where we looked after a lot of patients with aplastic anemia, which essentially just means bone marrow failure. And that, if you go back to the slide that I was showing you, where the pluripotent stem cell divides further down the line, in aplastic anemia, what happens is there's some form of damage. Sometimes we don't know why, but there's some form of damage to that original stem cell, which then results in the fact that the bone marrow is not able to produce the number of cells that it should be. And when all three cell lines are reduced with a combination of anemia, neutropenia, and thrombocytopenia, we term that pancytopenia. And the bone marrow, compared to the normal one on the left-hand side, which I showed you earlier, which has the right proportion of fat cells and the cells, fat spaces, and cells. You can even see a megakaryocyte there. On the right-hand side, the bone marrow is totally empty. You know, it's all just fat spaces we see, and this is the issue in these patients. So they can't produce enough blood cells because the bone marrow stem cell has stopped working. What are the causes of aplastic anemia? Now, it can be congenital, like most things can. Obviously, if we give too much chemotherapy to a patient, or if there is radiation damage in the system, like there was with the Hiroshima bomb, for example, then of course the bone marrow will stop working altogether. However, the majority of the cases that we see, about 80% of the patients that we saw and have done research in, we have now found is actually probably due to some kind of immune destruction, some kind of autoimmune system that's going off, that are mediated by a number of cytokines, including interferon alpha and TNF, that makes these stem cells stop working and the blood cell lines become reduced. So going now to single cytopenias, obviously anemia is probably the commonest blood abnormality that most of us will see in practice. And patients can present with it's just, I'm very tired, I can't, do what I've normally been doing, to those who come in really quite unwell and hemodynamically unstable. And there are two main, nutritional anemias that we see all the time. And I think that actually, because we use other parameters now that we have automation, although, I'm sure the crux of the discussion this morning is that in spite of automation, which has helped a lot in the lab, there's still instances where we have to make and look at the blood film, which is fantastic for those of us who love morphology. But on the other side, instances where you have somebody who is anemic with a hemoglobin of 10 and a reduced mean cell volume, or MCV, or say 75, it's a female and she has heavy periods when you ask, then we no longer make blood films in those patients, because as circulated on the left-hand side, they will be iron deficient because she's bleeding. And other causes of microcytic anemias are in the box on the left-hand side. And this is a film showing a hypochromic microcytic blood film in such a patient, and obviously with good response to iron, but it's always useful to sometimes document how iron deficient these patients are, or whether they are or not, because obviously in some cases you have a microcytic anemia that's due to other causes, like an anemia of chronic disorder, in patients with underlying cancers, with patients with renal impairment where they're not producing erythropoietin, and therefore they are anemic. But we can very quickly tease out what is going on doing iron studies if needed, or obviously in our part of the world, trying to rule out the hemoglobinopathies, and usually also the clinical history tends to guide us in that way as well. You know, if it's a child who is 1 or 2 years old with recurrent joint pains and swollen digits, then of course you're beginning to think of sickle cell. Again, you can make a blood film, but it's not exactly essential. What needs to be done now is hemoglobin electrophoresis. So the point I'm trying to make is that automation has maybe changed some of the instances where we would have been doing blood films before. Having said that, there are still a number of areas where we still need to do blood films and continue to do so. So of course, we've got the microcytic anemias on the one side, as described before. And on the other side, we've got the macrocytic and more nutritional anemias, you know, B12 deficiency, which, you know, we don't see too much, but I think we've been quite concerned with the recent COVID pandemic, because we do and have seen that patients who have had significant severe problems with COVID tend to be the ones who have nutritional deficiencies, but deficiencies of vitamin C as well as D2. But in macrocytic anemias, you've got your nutritional deficiencies, but also you will get patients who have abusing or take alcohol to excess. Liver disease also causes a macrocytic anemia. And then there are the more rare congenital causes, including Diamond-Blackfan anemia. And this blood film, as I'm sure, I hope, illustrates the really large red cells or macrocytes that we see, but also classically on this film, which helps to tie in the diagnosis, particularly with patients with B12 deficiency or pernicious anemia, is the hypersegmented neutrophil, which is shown in the at about 1 o'clock on the film, which is something that is pathognomonic of pernicious anemia or B12 deficiency. I put the two slides side by side because I thought the first one on the left-hand side, when you see it on its own, it's difficult to see that those red cells are actually small. But when you put them in comparison with the macrocytes, you can see clearly that the film on the left side was actually from a patient who had microcytic hypochromic anemia. So the other interesting blood films that we see in patients who are anemic, and something that I was very interested in and did quite a lot of work in, is patients who have autoimmune cytopenias. And the slide on the right-hand side is in a patient with a warm type IgG-mediated autoimmune hemolytic anemia, where, again, very classical features. Again, you know, Dr. Seiji was saying at the beginning that part of this CME is directed as those who might be doing part 1 pathology exams. And these are the kind of films that are given in an exam where you look down the microscope and you should know exactly what the diagnosis is. A combination of spherocytes together with polychromasia. Is it possible for people to mute themselves? Sorry, I can hear voices in the background. And also where the patient is very anemic because they're lysing their red cells very quickly, bone marrow is trying very hard to compensate, you get the nucleated red blood cells pushed from the bone marrow into the peripheral blood film. So this is classic warm type autoimmune hemolytic anemia in a patient whose hemoglobin was actually 6. And this was a congenital hereditary spherocytosis patient who we referred to the surgeons and had a laparoscopic splenectomy, which returned their hemoglobin to normal. So also, apart from the anemias, we have a number of red blood cell disorders where we're not now talking about the hemoglobin, but we're talking about the structure, the membrane, or enzyme deficiencies. I've already mentioned the hemoglobinopathies. And with the membranopathies, there are 2. We talked about hereditary spherocytosis. This blood film actually comes from a member of my family who was having a routine check. And lo and behold, we discovered that we had hereditary elliptocytosis, which is an autosomal dominant condition which actually runs through our family. So the majority of us have red blood cells that look like this. Now, with the membranopathies, if the hemoglobin doesn't drop below 11 or so, then majority of the people do very well without any intervention. It's only when, as in the previous slide, the hemolysis is really quite aggressive. And then usually by taking the spleen out, you can maintain a good hemoglobin level. I'm sure this blood film is something as common to the majority of people on this talk, because obviously we have the highest sickle gene in the world. And we now know that this is related to the fact that malaria in the area, in the region, resulted in patients with sickle surviving because they, became resistant to falciparum malaria, whereas those who had the AS phenotype probably succumbed. So beautiful sickle cells on this film with target cells. And again, the kind of exam vignettes that you get is that in hemoglobin, this is hemoglobin SC with loss of sickle as cells, whereas in hemoglobin C disease, you get mostly target cells. And then the differential diagnosis there is that has the patient got some kind of liver abnormality. So looking at abnormal blood results, and as part of this talk, I thought I'd mention polycythemia, which is an increase in the red blood count, which could be primary because the bone marrow is just making too much, because it's lost that switch response to erythropoietin, and irrespective of the fact that the patient has enough EPO, it just continues to make red cells, or is secondary to the conditions that I've listed there, particularly to do with hypoxia, smoking, chronic lung disease, but also from our point of view as Marcel Ruth, there are EPO producing tumors. And more recently, actually, we also know that in some patients with benign uterine fibroids, they can also produce too much erythropoietin and end up with a high hemoglobin. Because of automation, this is not something that we actually do blood films in anymore. It doesn't help the diagnosis in any way, but I just thought for completeness, as we're talking about the abnormal blood results that we can get in the lab and how we should react to them, this is just there for completeness. So we talked about the red cells, anemias, microcytic, small red cells, macrocytic red cells, and also how we differentiate between the nutritional causes or iron deficiency and so on. Moving to the white cells now, of course, neutropenia or a reduction in the white cell count becomes quite significant when we're looking after patients. Now, in particular, if you get abnormal or low white cell results in the laboratory, the speed with which you need to respond to that result goes with the classification. So if you've got somebody whose neutrophil count is less than 0.5, then essentially the people in the lab should not go home until they've gotten a doctor to make sure that they get that patient in. And if that patient has got a temperature, then they need to be on intravenous antibiotics immediately. And this is where I sort of emphasize to the laboratory staff that they are essential parts of our clinical work, because without them flagging up abnormal results quickly, we will not be able to look after the patients in the way that we should do. Now, of course, there are a number of causes of neutropenia. And when we're looking at blood films, we look for a way to confirm that there are no neutrophils there. But, some viral, sometimes you get large granular lymphocytes. Of course, you can, do your thick and thin films, which will be discussed a bit later on in terms of looking at malaria. But in particular, from our point of view, we need to ensure that this patient doesn't have some kind of bone marrow pathology like acute leukemia or aplastic anemia. And this is just, a patient that we had recently who was neutropenic with a neutrophil count of less than 0.5, and actually in the end fulfilled all the criteria for aplastic anemia, a patient in his 40s. And again, it's just to bring to your attention that, we have only been operational for about 7 to 8 months at Marcel Ruth, and we've already seen a patient with very severe aplastic anemia. We've already seen 3 or 4 patients with acute leukemia. These conditions are not as rare as one would think they are. So this patient had pneumonia. And again, I forgot to circle, but if you look at the area where there's the nose or the nostrils, you can see that on the left-hand side, they're the patent sinuses, whereas on the right-hand side, there are no black holes because that whole area was full of fungal infection, and which is a result of chronic immunosuppression due to neutropenia. Patients can get fungal infections, including lung aspergilloma or even mucor in their nostrils. So we talked about the causes of neutropenia. One point to make and to really hit home with, because it's very important, that the normal range that we tend to use, which tends to be about 2 to 7 in the textbooks, was made for Caucasian populations. The neutrophil counts are frequently lower in our population, in Africans, in African Americans. They don't tend to be lower than 1, but in patients, as long as you can get the historical counts, historical blood counts are amazing. Historical blood counts help you really determine, is this something that the patient has had all their lives, or is it actually quite new? Before you start investigating and doing a bone marrow test and so on, if you ask the patient if they got blood counts from before, and if their neutrophil count has been around 1 or just above 1, and they've never had any infections, then it's most likely this is a benign ethnic neutropenia, which doesn't need anything to be done about it. And all you have to do is reassure the patient. So that was low white counts or low neutrophil counts. Clearly on this blood film, this patient has too many, because I said you need 2 to 5 neutrophils per high power field is normal, and this is certainly more than 5, and some of them I think are granulated as well, and this helps to look at why has this patient got a high white count. And essentially there are 2 reasons why. On the one side, it's reactive, and the commonest reason is infections. But obviously we have to think about the fact that it could be a patient being on steroids for their asthma, for example. And on the other side, it's more of a neoplastic situation, or myeloproliferative disorder, in particular, CML. With CML, you tend to get the basophilia with it, or eosinophilia, but basophilia in particular. Those kind of things are the kind of things you look out for to look at that. Obviously, in a clinical scenario, you measure the CRP. I mean, and also, has the patient got a fever? Are they unwell? And if the CRP is very high, then it's more likely than not that this is due to an infection. In CML, you're not going to get a raised CRP. So those are the kind of things that help to determine what's going on. So I'm not going to, I think, just from a clinical point of view and the fact that with CML, we now have targeted therapies that has totally changed the way we manage these patients. So there's chronic myeloid leukemia. And of course, now there's chronic lymphocytic leukemia, which is where there's the lymphocytes that are increased. This is something that's not uncommon with age. A nice blood film there showing the lymphocytes, increase in lymphocytes, but also these smudge cells that we get in CML, which tend to be when the smear is being made, the cells are damaged and you get this smudge cells. But actually, they've been found in studies that they are actually important in terms of the response that these patients have to treatment and with survival. So that's looking at white cells and moving to platelets. Again, the normal count is as on the slide. And of course, when the platelet count is low, the patient is at risk of bleeding. Again, on this, the peripheral blood smears. On the left, you can see the platelets. They're enough for high power fills, and on the right, there are hardly any in a patient with severe thrombocytopenia. And these are the issues from a clinical point of view. The patient obviously can bleed into their skin, which may not necessarily cause them a massive problem, but we do have patients who will bleed into the back of their eye or have an intracerebral hemorrhage. And certainly if the platelet count is less than 30, then one needs to really be worried. Although the first thing you do when you have a low platelet count, which I think is on the next slide, is to look at blood film, because you want to check, is this a real count? So when the lab person says or gives you a result saying platelet count is 30,000, but the patient is well, doesn't have any evidence of bleeding, the first thing is to look at blood film. Are the patient platelets clumped? Are there large platelets? Because with automation, what happens is that the machine doesn't recognize these larger cells because the platelets are clumped together and doesn't count them as individual platelets. I mean, I know people like to do sort of the citrate sample and the EDTA sample because you can get in vitro clumping of platelets in the EDTA bottle. But for me, I think the blood film is the best place to look, because not only will you see whether the count is normal or not, it also helps you to make a diagnosis. I mean, is this immune thrombocytopenia related to chronic lymphocytic leukemia? Is this low platelet count in the context of myelodysplasia or an acute leukemia, or is this some kind of DIC type problem going on where you're going to see your schistocytes or fragmented red blood cells? So the blood film is, it really, really helps to make a diagnosis very quickly. And then going to the other extreme of platelets and just sharing a clinical vignette with a patient who presented recently to us, the 37-year-old young man who had had temperatures over the last 18 months and had a high platelet count on his blood count. Interestingly, has a family history of lymphoma, otherwise well, with no clinical features, no enlarged liver or spleen or anything. But these are his counts over a period of about 6 months. And what was clear, which is why I'm saying, so he presented to us in June with that platelet count of over 1,000, and you asked for historic counts. always helpful historic blood counts and shows you that this has been going on for quite a while. But he was well in himself, totally asymptomatic. So the most likely diagnosis is a primary bone marrow myeloproliferative problem, because the differential is a reactive thrombocytosis where the patient is bleeding or the patient has an infection or inflammation and the body is making more platelets in response to that. Now, the reason why it's important to know whether this is reactive or secondary is that in reactive thrombocytosis, the platelets are not so sticky. They don't tend to cause blood clots. And so you don't need to put this patient, in fact, you mustn't put this patient on aspirin because they will bleed. So it's really important to think about, okay, I mean, a young man walks into your clinic, came from work, is well, and has platelet counts that have been high for 6 months, then is not likely to be reactive. But if it was somebody you went to see on the wards who had an infection and has been unwell, has a high white count, high platelet count, then please, please do not put those patients on aspirin or any anticoagulant thinking the high platelet count is going to cause blood clots, because it will not. And putting them on anticoagulants will actually be detrimental to them. But anyway, in this young man, very clearly, primary bone marrow essential thrombocytosis, and we did start him on aspirin. But I'm just going to share with you the data from the Research Council PT1 trials, where you divide these patients into low risk, intermediate, and high risk. And he fell into the low risk group because he's young and he has no cardiovascular problems or anything else, and all he needs is aspirin. But it's well defined in terms of which patients need treatment, and the threshold for treating is greater than 1,200. So this patient doesn't need anything else apart from aspirin. So we've moved very quickly through, abnormal blood counts where all the cell lines are low, so aplastic anemia, to the single cell lines, low and high, anemia, polycythemia, neutropenia, and leukocytosis or lymphocytosis, and thrombocytopenia and thrombocytosis. One other, I think, what I would say is a pretty blood picture on a blood smear, but also very useful in terms of diagnosis, is something called a leukoerythroblastic blood picture. And essentially, in Latin, what it just means is that you have got the immature white cells and immature red cells that are normally only in the bone marrow. You have them pushed out into the peripheral blood film, and a combination of the immature white cells and red cells together on the blood film is what is called a leukoerythroblastic blood picture. And the causes of this on the slides, and the commonest one really is bone marrow infiltration by some condition, either leukemia or other solid tumors, although very recently we have made a diagnosis of primary myelofibrosis in a patient that presented to us recently. I think I've got 2 more clinical vignettes to quickly go through, but there are points behind the reason why I'm sharing them with you. And in this particular patient, the point of sharing this with you is the fact that when we see abnormal blood counts, we must consider making a blood film. In this patient, it took more than 6 months when he first presented with a hemoglobin of 9.9, with a high MCV, a low neutrophil count, and a low platelet count, so pancytopenia. And it was not until we saw him in May of this year that we actually did a blood film. He had been seen in a number of other hospitals, and no blood film had been done. But when we did the blood count, actually initially, if you ignore the slide on the left-hand side, his blood film was like the one on the right-hand side, which shows quite nucleated red blood cells and immature white cells, so leukoerythroblastic blood picture. But also, if you look closely at the white cells that you have, even the ones that have nuclei, they're only bilobed, so your pelgaheroid type white cells, which are a classical dysplastic type of white cells. So he had myelodysplastic syndrome, but very, very quickly, and this is real life, this is a patient that we've seen, he moved to the slide on the left, which is an acute myeloid leukemia. So this patient, had been seen in a number of places with abnormal blood counts, but no peripheral blood count done for 6 months. And by the time we picked him up, he had already transformed into an acute myeloid leukemia. I'm very happy to say that he's now had, I think, 4 cycles of chemotherapy according to the NCCN guidelines, combination of azacitidine and venetoclax. He's gone into remission, but he does have poor prognostic cytogenetics. So his long-term survival is probably not going to be that great, but at least he remains very well. He's at home and coming in for his chemotherapy on an outpatient basis. So that point is about, making sure that please, any labs that you're working with, either your labs in your hospital or if you're in the private sector, the labs that you send your samples to, once there's abnormal blood results, they should be encouraged to make a blood film to ensure that we make diagnosis quicker, because when we make them quicker, then we can actually treat these patients properly. And then the last one, I think, is just something which I feel is quite topical at the moment. So this is a 65-year-old gentleman who was transferred to me from another hospital, and again had abnormal blood counts, but in particular just had low platelet counts. And the low platelet counts had actually dated for another month or so before the ones that you see, the top one on the slide. But interestingly, when I was talking to him, he had received 1 dose of the AstraZeneca COVID vaccine, prior to which he had been well, but after the vaccine, he'd felt unwell for about a week with fever, otherwise okay, although he's a known hypertensive and diabetic. I was treated for sepsis at another hospital, but the platelet count remained low. They had done a CT scan, they'd done a bone marrow. And I just thought, okay, at this point, I think I'd seen 3 patients with low platelet count following the COVID vaccine. And of course, there is now quite well documented thrombocytopenia following the COVID vaccine, which has been published by more than 1 group. And even the American Society of Hematology has now defined it as a condition. So all we did with this gentleman was just hold off, and actually his platelet count got better and has remained normal since then. So it's just something to flag. And then there's more from the laboratory point of view, from Pezeshki and his co-workers, looking at what are the blood cell smear abnormalities that we see in COVID-19 patients. What is interesting is that the commonest finding is this smudge cells that I was discussing with you earlier in the context of CLL, chronic lymphocytic leukemia. Apparently in COVID patients, a lot of them get smudge cells, but unlike in CLL, where it works with the prognosis of the patients, there's some correlation between the number of smudge cells and survival in CLL. In these COVID patients, none of the abnormalities that are seen were found in this particular study anyway to have any relationship with how well the patient did or not. So smudge cells in about 60% of the patients, atypical lymphocytes and immature neutrophils, leukoerythroblastic blood films, large granulocyte lymphocytes, which I think you can sort of imagine will happen, because this is a sort of a viral infection that's going on. And in those who were very unwell and admitted to ITU, we can imagine these things happening. And just to mention, because I alluded to it earlier, I haven't actually seen a case yet, but together with the low platelet count that you can get in following the COVID vaccine, you can get blood clots as well. And these patients tend to be quite unwell with these, so it's something to know about. As you know, any patient who's had a COVID vaccine within 4 to 6 weeks and has abnormal blood parameters or whatever, just have it there at the back of your mind. So in summary, because I think I was given 45 minutes and I think I've just about come to that. Since being back in Lagos and being operational at Marcel Route, I have been surprised but intrigued by the fact that we're seeing more hemato-oncology cases than I would have expected that we would see. If you look at the background database of cancers in Nigeria, you don't tend to see too many of these hemato-oncology type of conditions, but actually we have seen quite a few already. The point I would like to emphasize is that when blood results, the automated blood results show any abnormality that is not straightforward, you know, like anemia, microcytic anemia, and so on, please do get these blood films made in quickly because it will help to manage these patients. And in particular, you know, is picking up things like leukemias and so on. So obviously, with everything that we do, we can never do them on our own. And I'm extremely grateful to my team who, I think when we launched formally in April, we had about 30 odd staff, and we now have about 64 staff who are working extremely hard to look after all these patients, in particular the hemato-oncology ones who require a lot of blood product support. And we've really done well with them, but it's been quite a lot of work. So thank you very, very much for listening to me, and I'm happy to take any questions or comments that you may have. Thank you. I'm going to stop sharing now. I think you're muted. The lady who's speaking, you're still muted. You're
okay,
muted.
While she's
yes, trying to unmute herself. Yes.
While she's unmuting herself, I just want to thank our first speaker, Dr. Modupe Elebute Odunsi. And when you were being introduced earlier, I think we had just about 30 participants. Now we have 130. So I think there was a very important aspect of your introduction that was left out, and that is that you are the daughter of the chair of the Board of Trustees of the Medical Women's Association of Nigeria, Professor Oye Elebute.
Correct.
So it is wonderful that we're having you, and I want you to send our best wishes and kind regards to our chair BOT.
I will. She's very, as you know, she's extremely passionate about the medical women.
Yes. Yes.
Extremely passionate. So she was very excited that I was going to be giving this talk. So yes, thank you very much.
So I have a question. That's why I also raised my hand again. Yes. And it's because I want to find out these blood smears.
Yes.
Is there any value preparing side laboratories to be able to do this, like over a weekend period when you may not have your regular lab results available, or during a call period? Because many of it's not only the pathology residents, several other faculties, family medicine, community health, they are all expected to have skills and in these areas.
Yes.
And the understanding is that you may go to a rural area, and the time you will ship or transfer your specimen to get to the consultant hematologist, it will take donkey days. So what we are looking at now is there value setting up side laboratory procedures to do blood smears and some of these tests which you have shared? Thank you.
You know, I think that's a really interesting question. I really do, because when I first came to Lagos, I assumed even the bigger hospitals, I hate to say, that I thought, I would just walk into the lab, because before Marcel Ruth was ready, I was actually practicing in a number of places, and I just walk into the lab and say, so have you made a blood smear? And they'd be looking at me like, what am I talking about? So I think we have an issue, because even in the private sector, okay, they may not be that interested in the laboratory side of things, but they have the automation. There were not, adequate processes to get these blood films done. In fact, actually, since we set ours up, I've actually gotten the staff from a number of these private hospitals to come to us on a weekend to learn how to make these blood films.
Perfect.
Yes,
Perfect.
we've done that already. I do think it's important. I also am a bit reluctant to say yes, let's get them in it, because it's the interpretation as well.
Okay.
So even if you make the bloods, although I suppose if you could make them, then you could ship the slide off
Yes.
to somebody, so for example, I sometimes get a second opinion from some tricky morphology from abroad. So yes, that's the other way we could do it. I mean, mostly on my bone marrow, it's not on my peripheral bloods, but I mean, so that's one thing. It might not be a bad thing to think about, actually. And I think something like the context of medical women working with the College of Pathologists may be a good way to do it. I think that would
Brilliant, brilliant. Thank you so much. I will
Yes.
send that information to my successor, because I have just 13 days left.
Yes.
Dr. Nadim, are you with us so you could moderate the remaining questions? If there are no questions, we can now go to the next speaker. Dr. Nadim, come on and let's...
Thank you very much for the presentation. And there are some questions in the chat box. I will just read them as you address them. I understand you are on a schedule and you need to read.
Okay, look, I'm in chat box.
Okay. One of the questions says, for those sickle cell disorder patients who have done a bone marrow transplant, how does the blood film look like? Does the blood film ever break down?
Okay, so that's a very good question, actually. So in sickle cell transplants, okay, for patients who do well from the transplant, there are a number of scenarios. One is that the patient becomes AA because they get 100% chimerism from the donor. Do you understand? So in those patients, the blood film goes back to looking normal. There are no sickle cells anymore because the patient has become, their genotype is now AA, right? However, for a transplant to be successful, you don't have to have full chimerism. So some patients, they don't take, their genotype doesn't change to AA. They have a mixture of AA and the S still going on, so their blood film will look like AS.
Thank you very much, ma'am.
Okay.
The other questions, I'm going to send the other questions to you.
Yes.
And you will answer it. I will send it to them in the Telegram group. So we are going to proceed to the next lecture.
I have a question.
Making our time to
Good morning,
Okay.
So,
I think you have somebody who is who really wants to ask a question. So, Dr. Ahmad, so maybe we let her ask the question and then we'll do the rest. I'm happy to do the rest.
Like in the chat box.
Yes, ma'am. Good morning, ma'am.
Good
morning, ma'am. Please let me ask my question.
Inbox, and you answer them. I will send it to them in the Telegram group. Will that be fine, ma'am?
Yes, absolutely, totally. I'm very happy to answer the questions, and then you can circulate them. I'll answer all the questions, and then you can circulate.
My question is, good morning, ma. Thank you for the presentation, ma.
Thank you very much. So we are now going to move on to the second lecture, which is a lecture by Professor Ibinabo. Let me make her the co-host. Okay. Can make her the co-host, Dr. Ibinabo. Okay, thank you very much. Now we are taking the second lecture, which is a lecture by Professor Ibn Abogoro. And I'm going to give you a brief, let me tell us briefly about her. She's a minute, please. She's a professor of medical microbiology and parasitology. She's the Associate Dean, Faculty of Basic Clinical Sciences at the College of Medical Sciences, Rivers State University. She's a honorary consultant clinical microbiologist with the Rivers State University Teaching Hospital and an adjunct lecturer with the PAMO University of Private Sciences, Rivers State. She's the pathologist, COVID Diagnostic Center, and a fellow of the National Postgraduate Medical College of Nigeria. She served as the Assistant Director of the Center for Malaria Research and Phytomedicine and Molecular Lab Lead 2, University of Port Harcourt, and its teaching hospital, respectively. She's a member of various research teams and editorial board of the Journal of Malaria and Phytomedicine and a reviewer for the international journals. And she has attended various conferences and received certified training both locally and internationally in leadership and management in health and good clinical lab practice, among other things. She's a member of various professional associations where she has and still serves in various capacities, as well as in her religious organization. She's married with 4 lovely children. Welcome, Professor Binabo Uduru. You are very welcome. And take us on the lecture on basic side laboratory procedures. Welcome, ma'am. Over to you.
Thank you very much, Dr. Nodim. Good morning, ladies and gentlemen. Special thanks to the executives and the scientific committee of MWAN, Rivers State. I'll just put on my video briefly. I think I'll turn that off later. Thank you very much for these opportunities. And I want to also thank the previous presenter for a very enlightening lecture. I'm going to be talking about basic site laboratory procedures as it relates to medical microbiology. And I have designed this presentation in such a way that it is it's quite basic and targeted at equipping us to be able to run our site laboratories, performing these simple procedures that could make a world of difference in our patient management. So I hope you can see my slides.
Yes, we can see.
Okay, thank you. Okay, so I'll proceed now. Okay, so I'll take through this outline. I'll just do a brief introduction, and then we'll basically be talking about gram staining, urinalysis, and then stool microscopy. Okay, so really, when we go through medical microbiology laboratory processes, particularly when it comes to microbial cultures, the idea is to make a definitive diagnosis, etiologic agents in that infectious disease process, okay? And to be able to, place our fingers on effective antimicrobials that would help to clear that infection. And so everything we do, it's targeted really at that, okay? And usually most processes in the laboratory go through the steps of microscopy, that's observing specimens under the microscope, a called bioamplification process where you want to multiply the number of organisms so that you can identify them, and then various identification processes, some very manual, as tends to occur in a lot of our laboratories in Nigeria, and some, of course, semi-automated and more automated, that can help us place our finger on the particular organism implicated in that infectious process. And then a susceptibility testing, stage where we can identify a range of antimicrobials that could be effective at clearing that infection. Okay, so it is important that we understand that all of the processes involved, from the clinician takes a decision to order a laboratory investigation to the point where the laboratory report is released to that physician, to help in his or her patient management. A lot of processes go on. And every one of those processes is very critical to the accuracy and reliability of your laboratory reports, and its usefulness, of course, to the clinician. So every single step of this is as important as, the analytic stage and the end result. So all of the operations that go on is what is described as a path of workflow. And you would observe here that it's, oh, I'm sorry, I'm not on slideshow. Make that a slideshow. Thank you. Yeah. Okay, thank you very much. So this goes through a pre-analytic phase, also known as examination, and an examination phase and a post-examination phase. The pre-examination phase should be regarded as much importance as the examination phase, because it's like the simple average, garbage in, garbage out. If you have a poorly collected specimen, a poorly stored or transported specimen, the end result would not be reliable, would not be accurate, would not be would not really reflect what was going on in your patient. So we must have that at the back of our mind. So a typical example would be investigation of a wound or abscess, for example. You would rather take an aspirate of that site than do a swab, because an aspirate will be more representative of what's going on in there, and so that's better and will give you a better result than just a swab. Okay, and particularly if you have a wound that is dirty, contaminated with environmental pathogens and pathogens from the hands of healthcare workers and so on, and you just go and swab the surface of the wound and take to your laboratory, you would end up isolating a lot of organisms that have no relationship really with the pathological going on in your patients. Okay, so also note the right specimen containers and all of that. Okay. Now, this is also a very important phenomenon we must appreciate, because there is a continuum from colonization to disease, which actually impacts how we interpret, and report our laboratory results. So organisms find themselves on body surfaces, themselves sometimes very transiently and sometimes more persistently, and that's called colonization. Okay, they really have not caused any damage to that body. The body hasn't mounted an inflammatory response against them. That's just a colonizer. Can easily be removed by decontamination processes, by hand washing and things like that. But when the organism goes on to begin to multiply effectively and invade deeper tissues, and the body recognizes it and mounts up an effective immune system response against it, we have an infectious disease process setting in. Now, a disease results when there's actually damage to the body at cellular, tissue, or organ levels, and it's actually, there's no fine line between all of these, but we could just keep progressing if interventions are taken. Okay, and we must understand, so that we don't report colonizers as pathogens. That's the implication of this slide. If there is no evidence of an inflammatory reaction, and the specimen was not got from the site of the infection, then it's most likely a colonizer, and so should not be evaluated and treated for, as that would lead to a barrage of other unwanted effects. So the gram stain, which is the first procedure we're going to talk about, is such a critical in any microbiology laboratory, and I call it the compass. Okay, you could have a map, which is our understanding of various organisms, how they look and what kinds of diseases they cause and all of that. What direction to take when it comes to identification of bacteria, cannot be made without a gram stain. Okay, it's that critical. It tells you which way to go in your diagnosis and identification of bacterial infections. Now, it can be direct or indirect. The indirect is called secondary, while the direct is what is done on the specimen, okay, not on colonies. Okay, so a specimen collected from a patient can actually be gram stained, okay, and that can do a whole lot for management of that patient. Now, this direct gram stain is what you can easily perform in your side laboratory, okay, and it helps in that it can give you a direction. So okay, among all the barrage of organisms that could be causing this infection, which am I dealing with? A direct gram tells you that. So you see a gram picture that looks like a certain set of organisms, and so you are able to now decide on an antibiotic that is likely to cover those sets of organisms, and start that as your empiric treatment for the patient while waiting for the definitive diagnosis and the susceptibility test result from the laboratory. Okay, so of course you take your sample and send to the laboratory, but with a bit of that sample you can perform a direct gram stain, and that can give you direction or help in your choice of empirical antimicrobial intervention. So that gives you timely intervention. We know that every delay in commencing appropriate antimicrobials on a patient with a septic condition increases mortality in many folds, sometimes 6 to 8%, higher increase in mortality with every 1 hour delay. So it's really critical. So this alone, can give a lot of directions. So if, for example, you have a patient with a meningitis and you have a CSF sample, you collect, send to the laboratory, but with a bit of that CSF sample, you perform a direct gram stain, and you see a gram-positive cocci, in pairs, looking lancet shaped. You already have pneumococcus in the back of your mind, so you can choose to pick antibiotics that cover the pneumococcus in your empirical treatment while waiting for the final result or definitive result from the laboratory. Okay, so this basis for the gram stain. The peptidoglycan layer, which is a component of the cell wall of the bacterial organism, is the basis. Now, in gram-positive and gram-negative bacterial cells, they differ. Okay, it's much thicker, the gram-positive cell wall, and thinner in the gram-negative. So because of this thickness, it's able to retain the first stain applied during the staining procedure, which we call the primary stain, and not let it go, even when you attempt to wash off by decolorizing. However, the gram-negative easily loses that primary stain, because of its thin peptidoglycan layer, and so takes on the secondary stain, the second stain you apply. Now, these two stains have very different colors, blue, purple to red, so that they are very clearly different, and you can easily tell what your organism takes, which color your organism takes. These are shapes that bacteria can assume, okay? Cocci, here spherical cells, rods, we can see down here. Some of them can actually be spiral, like the spirochetes tend to, so these are the basic things. So when you perform a gram stain, what do we look out for? One, the color of the organism. We look out for the shapes. Are they cocci? Are they rods? Are they spiral? Are they, what are, and then thirdly, we look out for the arrangement. So, and that helps us to place the organism in one group or the other. So what do we need? Gram stain. On my left, you have various reagents and materials required, glass slides, the gram reagents, immersion oil that helps, viewing under the ×100 magnification. We need a water to wash. We need a Bunsen burner, a flame, a source of flame to help with fixing. We need our loop to apply the specimen onto the glass slides, and then a light microscope view. Of course, if we're performing a direct gram, we need specimens, or a secondary gram. Now, these are the gram reagents. Okay, I've highlighted CIAN in bold and with the appropriate colors. Crystal violets or methylene blue can be used as primary stains, the purple to blue colored stains. Okay, and then iodine is what we call a mordant, Lugol's iodine. It helps the primary stain to bind more avidly to the cell wall, and alcohol helps to, or tries to decolorize the primary stain of the bacterial cell wall. And then a secondary stain, which can be any of these, neutral red, dilute carbofluorine or safranin, are applied. These are all red stains and can be taken up by the bacterial cell. So this is the procedure. Now, what I'll advise is that at your side lab, you can draw up this actually as a bench and have it probably laminated and put over the staining area so that anybody who comes to stain can follow these steps very easily. You don't have to memorize them all, of course, with usage, get used to it. So it just involves, getting a clean, grease-free slide, okay, without grease, so that your smear can hold onto the slide properly. Make sure it's clean, okay, and then applying your specimen or applying colonies. If you're dealing with colonies, you have to apply a bit of normal drop, just a drop of normal saline first, and then emulsify your colonies into it, and then you smear. But that, of course, won't be the case with a site that most dealing with just direct specimens. So apply the specimen onto the smear, the slide, allow it to air dry, and then be, fix. Fixing just involves passing abruptly through the flame about 2 to 3 times. And then, of course, you should make sure you haven't overheated, because heat will destroy the proteins in the cell wall and impair the color of the gram stain. So you can just, when you touch the back of that slide on the back of your hands, it should just feel warm and not hot. Okay, and then after that, you can go through the staining process. Just involves one stain after the other, and washing in between. Okay, for the decolorizer, 70% alcohol requires just a few seconds before it's washed. Okay, and then with acetone, as you are applying, you just, as soon as you're done applying, you begin to wash immediately, because it will decolorize the smear, much harshly than 70% alcohol. And then, of course, you get the slide to be dried, and then place a drop of oil immersion on it, and view under the oil immersion lens, which is the ×100 objective lens of the microscope. Okay, and when that is done, these are some things you could observe. These are gram-positive cocci, quite common, causes of human diseases. Okay, and they can assume various arrangements. These, you can find some of them here in clusters, okay, which is typical of staphylococci. Okay, you can have them appearing in short chains and in pairs. Here you have a typical lancet-shaped pair, end-to-end pairs. This is what we call diplococci, and quite characteristic of Streptococcus pneumoniae species. And then we have over here chains, which is typical of Streptococcus. Have a mixture, but the predominant arrangement is what might be helping you make up your mind on the possible etiologic agents. Okay, and here we have gram-negative rods on the left. You can see they are more rod-like, not spherical, and appearing red, pink red, showing that it took on the secondary stain, and let go of the primary. Okay. Now, beyond bacteria, the gram stain can also help with identification of yeast. So if your patient has a vaginal discharge, or a specimen at any site you strongly suspect have a fungal infection ongoing, you could take a smear from that site and make a direct gram, and you'd find this. They look like gram-positive cocci, but they're actually slightly larger, more spherical, and they could be budding, as you can see here, the process of asexual reproduction, where you have more than one cell attached to each other, showing actively replicating. Okay, so these are yeast cells, and that can give you just a rapid diagnosis in managing your patients. Great. So that's it with gram stains. Urine analysis. Urine analysis, commonly called urinalysis, is actually a very useful screening method, which involves chemical and microscopic examination of urine. And we know that urine is actually an ultra-filtered of blood, and it has its typical color, which spans from somewhere yellow, various shades of yellow or amber, or straw colored, and that's because of the urobilin pigment, which is a breakdown product of hemoglobin, okay, present in the urine. Now, it can be useful for both infective and non-infective conditions. Okay, so what processes do we go through when we carry out a urinalysis? We can do a macroscopy, which involves grossly examining your specimen. That is as important as the other steps, okay? The gross appearance of urine tells a lot about the urine, okay? Then the chemical analysis, in some settings, that's done under the chemical pathology laboratory, but it's some examination that's one examination rather, that's very important, in helping you to make a rapid decision about your patient's condition in your side laboratory. And then, of course, microscopy. Okay, microscopy can also tell a lot more. So normal urine is as this is, usually very pale yellow, pale amber, to amber, and then of course it deepens in intensity based on the degree of hydration of your patient. Okay. The other thing about normal urine is that it tends to be clear. It is clear, you can see through that urine. So when urine becomes turbid, when it begins to become colors other than amber or pale yellow or yellow, you know, then we begin to think, you know, that there might be other constituents and other, you know, metabolites and various other compounds present in that urine. Okay, so disease states, medications, foods we take, food colorings, and all that actually impact on the color and turbidity of the urine. Now, these are some common colors you can find from patients with various disease conditions. This is red urine, obviously, bloody, you know, and this is what we call the Coke-colored urine, or some Lipton-colored, usually appears brown-black, you know, and down here, two colors that are possible, but I would say here that I've actually never seen any of these in my practice, but they do occur. Okay, you can have green colored urine, you can have blue colored urine, and so on. So urine should be collected in a container which is clean. Just cleanliness is enough for urinalysis. You don't have to have a sterile container because you're not going through a culture process, and it should be leak-proof for infection control purposes. You don't want urine leaking around your laboratory, other materials to be working with, so you don't get laboratory stuff infected. And then of course, it should be wide mouth, okay, for easy collection of the urine. Now, some of the things we can observe that are not normal on macroscopy are, one, okay, when urine is very frothy, it's actually an indication that there is a large amount of protein in that urine. Okay, like we can see with patients with diabetic nephropathy and hypertensive nephropathy and various other renal diseases. Proteinuria can occur. There can also be orthostatic proteinuria and so on, which gives urine a fully frothy appearance. Okay, now urine could also be milky white or cloudy, and that can be caused by a range of things. Okay, presence of pus cells in urine can make it creamy colored. You know, milky white can make it less clear, begins to appear turbid. Okay, the presence of crystals, which are actually minerals that crystallize because of the acidity of the urine, you know, and then cast are tubular structures which are formed with renal tubular damage in various in a spectrum of renal diseases. Okay, the presence of organisms can also cause that. Chyluria, which is the presence of lymph in the urine, can be a cause of whitish urine. Okay, and that you can find in the uriasis, for example. Now, urine can be, okay, and one very important that is the presence of blood in urine that you can find in urinary tract infections, in urinary schistosomiasis caused by Schistosoma hematobium, in acute glomerulonephritis, in trauma, okay, traumatic disorders that affect the renal system. Kidney stones, you know, can also lead to blood in urine, okay. People with porphyrias can have the urine appearing red as well. Okay, and of course, if that urine is exposed, it could turn purple, you know, on exposure to sun. Now, beetroot is a vegetable that is taken, and beetroot actually can color urine. So various other things can color urine, give it an orange, reddish appearance, things like rifampicin, you know, phenozip, pyridine, and various other drugs too can affect that. We can have Coke-colored urine, like I mentioned earlier. And this can happen when you have breakdown products of red cells like hemoglobin. You can have myoglobin also present in cases like rhabdomyolysis, you know, present, giving the urine a brown to black coloration, okay? In acute tubular necrosis, you can have a really dirty brown, okay? Melanoma can make urine black. Alkaptonuria, a condition where there's small metabolism, tryptophan can give you black urine, phenol poisoning, and so on. There's a long list of drugs that can do that, okay? Yellow-green to yellow-brown or brownish urine can be present in bilirubinemia. So when we have liver disease, liver failure, there can be various intensities of yellow to brown, green-colored urine by that. And then of course, extreme cases where urine is actually blue or green outrightly can be seen in some congenital anomalies like you have in babies with a familial hypocalcemia syndrome where they have bluish and diaper. due to a disorder in metabolism. You can have people who have IV methylene blue, given to them as for therapy of various conditions. Down Pseudomonas infections, the urine sample that has a lot of Pseudomonas in it on standing can begin to appear greenish. Okay, asparagus, food colorings, and various other drugs can be implicated in these. Okay, so this is what is done when chemical analysis of urine is performed. This is a very straightforward and simple method. Okay, and can be easily done in the side lab with the use of what we call a dipstick. A dipstick is a paper impregnated with various chemical constituents, and dyes, aimed at detecting various components of urine, possible components of urine, by the color change. And then, of course, they quantify the amount of that substance based on the degree or intensity of the color. And it's very simple, performed according to manufacturer's instructions. So follow the manufacturer step by step, and we must ensure that the kits have neither expired nor deteriorated, okay? One very easy way to tell is to make sure that the leukocyte esterase pad, which is usually at the top, is still in its pale color. It hasn't changed to pink or any darker shade, okay, to make sure it's not deteriorated. Because as we open, moisture begins to collect and it could deteriorate. So another important thing is to always remember to close them tightly, after use, to prevent them deteriorating. Now, duration is very important. It's critical because these are timed reactions, okay? And every manufacturer gives his own timeline for analysis. So we must follow them and do it appropriately, okay, based on the time. Because as time runs, the color intensity increases, which will ultimately give you false positive results. So combi sticks come in various designs and various number of metabolites that they can identify. So you can have those that identify just 2 components commonly used in antenatal side labs, okay, and then those who can identify about 9, 10 to 11 components of urine. As we can see here, this can do about 11, okay, and these are all very important in various ways. Okay, so in interpretation, I have divided them into infective and non-infective conditions. For the infective conditions, usually urinary tract infections are what we try to identify or screen for using a dipstick. Now, some laboratories, some countries, and laboratory setup have made it their own policy to always screen a urine sample by urinalysis for the presence of markers of a urinary tract infection before proceeding for cultures, okay, and susceptibilities, okay? That will help to save cost because you can tell whether this urine fits into what is likely, containing a uropathogen or not. And that can help you decide on whether to go ahead to do a culture on susceptibility, okay? Because just proceeding with the whole process, through analysis, culture, susceptibility, and the whole could actually lead to a waste of resources because quite a lot of urine samples that come in for microscopic culture and sensitivity in our laboratories generally turn out to be not representative of a UTI, okay? So we can't screen, and that's where urinalysis comes in. So in your side lab, you can perform a quick urinalysis. And if you have markers that signify a UTI, like the presence of leukocyte, okay? Of course, beyond the macroscopy, the color, the turbidity, that gives you an idea, right? And then you have leukocyte esterase, which is produced from the white blood cells present as a marker of inflammatory response to the presence of the infecting agent, okay? And then nitrites, which is present when you have nitrate reducing microorganisms. Commonly the Enterobacteriaceae, they reduce it to nitrites, which you can now detect using the dipstick, okay? And then the presence of blood, okay? Now, we did a study sometime and we found that nitrite on its own is the most, has the highest positive predictive value, urinary tract infection, and then followed by that, and we had the combination of leukocyte esterase and nitrite. Okay, so when you have those two in combination present in your urine, likely that urine will be positive on a culture. Okay, and so that can help you decide whether to go on to ask for a culture, which the patient, of course, has to pay for. And you could have saved that patient if you had done this first, before ordering for an MCS. Now, for non-infective conditions, there's a whole barrage of them based on your combi or multi-sticks capability, okay? You can have glucose, which can help easily screen for diabetics, okay? Blood in urine in renal pathologies and glomerulonephritis, you can have blood in urine, and that, of course, schistosomiasis and so on. You can easily run that, okay? For liver diseases, presence of bilirubin, ketotic states, severe starvation can give you ketones in urine. Hemoglobin can be present in urine, for example, in severe malaria, where we have hemoglobinuria, patient passes cold-colored urine, which will be picked up by the dipstick, okay, and various other conditions that lead to that. And then, of course, the more dehydrated your patient is, the higher the specific gravity, okay? So that would also help in metabolic conditions, okay? And then, of course, the pH, of the urine tells about the metabolic status of the individual. Remember, we said urine is an ultrafiltrate of the blood, and so it's a reflection actually of the metabolic state or physiologic state of the body. Okay, so these can be very, very useful, and I think every side laboratory should have this handy. So microscopy goes a step further, okay? So where there's the capability to carry out a microscopic examination, all you need to do is to just centrifuge your urine, put it in a clean test tube, centrifuge it, for just about 5 minutes at 2,500 revs, okay? And then decant the supernatant briskly, leaving your sediments, which you now put onto a glass slide and examine. Okay, so these are the basic things you need: just test tubes, your centrifuge, glass slides, and then you cover with a cover slip, a little glass slide, and then examine under the microscope with a little light. And that can show you all of these, okay? So these are possible findings: epithelial cells, which actually just show that it wasn't a clean cut urine. The more epithelial cells you have, the more likely this urine will have contaminants. It just shows that a lot of epithelial cells were washed off while the urine was being collected. Okay, and then leukocytes, of course, show you an inflammatory process going on. Of course, with bleeding, there could also be white cells along with erythrocytes, okay? Crystals, I mentioned earlier, minerals that crystallize in the urine, and they can be quite a large variety. Now, one asset you should have in your side laboratory actually should be a little atlas, okay? A picture atlas that can show you the different kinds of crystals that can be present, the cast and all that. So you can easily just look at them and make your decision on what you're dealing with. So calcium crystals and so on, we'll see on the next slide. Casts just take on the tubular shape, and they can be a variety. Okay, yeast cells, a woman who has vulvovaginal candidiasis, yeast cells can be washed off into the urine and so on. People with diabetics and all of that can also have these presentations. So it can be very useful. So these are some of the possible findings. Here we have white blood cells, pus cells, the multi-lobed cells, multi-lobed nuclei rather, show us the presence of pus cells, and because you can easily view your... Can you mute Dr. Shitu? Thank you. Okay, so these are yeast cells in the wet mount, okay? And then red blood cells, very easily deformable. Just tap your microscope slide, they tend to change their shapes. That gives them away very easily. And then, of course, here we have a I'm sorry, I was muted. Okay, I'll just repeat that the calcium oxalate crystals can actually be present in the urine of people who are on calcium-containing drugs. Okay, so it tends to crystallize as the urine becomes more acidic on standing. And then, of course, we have casts. Casts can be cellular, where you have red cells forming the cast, contained within the cast, where you have white cells. There can be hyaline, looking glassy. Okay, those are quite innocuous, okay, and so on. Casts are actually a very important marker of renal tubular disease, and can be very useful to the nephrologist when managing their patients. Great. So I'll go down to stool analysis. Stool analysis is actually one important method as well, and process as well, that can be useful in your site laboratory, and it involves the examination of stool using microbiologic and chemical methods. Okay, but I'm going to just focus on the microbiologic methods, okay, which can easily be done in your site laboratory. Okay, it can be both diagnostic and screening. Okay, so of course, the patient comes down with symptoms, of gastrointestinal disease, commonly diarrhea, okay, or dysentery, where we have blood in stool. Okay, diarrhea, we know it's passage of 3 or more loose or watery stools in a 24-hour period, or way more than that, and that will warrant a stool analysis. Okay, so in patients with anemia, stool analysis can also be performed, to help decide on the etiology of the anemia, because we know that parasitic infections like the hookworm infections can lead to iron deficiency anemia, as we heard in the previous presentation. Of course, for carrier states, for intestinal infections, particularly for food handlers and all that, it can be done so that they can be appropriately treated and prevent infection of their customers. And then, of course, in the case of public health outbreaks and for surveillance of disease outbreaks, intestinal disease outbreaks, we can carry out stool analysis. So basically, a macroscopy and a microscopy can be done. Okay, now these are a list of possible etiologic agents for diarrheal diseases, but stool microscopy or stool analysis actually helps primarily with diagnosis of parasitic diseases. Okay, so protozoan infections like Entamoeba histolytica that causes amoebic dysentery, okay, and the worms, the helminths, okay, like hookworms and the tapeworms and good old ascaris, okay, they can all cause intestinal diseases which can present with diarrhea, and warrant a stool analysis. For bacterial diseases, usually a culture will be required. However, on microscopy, stool microscopy, it's possible to have an inclination of whether there's likely bacterial involvement, and that can warrant further analysis of your sample by microscopy, by culture rather, and susceptibility when necessary. Okay, so of course our specimen has to be collected in a wide mouth, clean container. Okay, remember infection prevention and control at every stage of your management. Okay, we don't want to go home with our patients with all disease conditions from patients and others because we're trying to intervene. Okay, so let's maintain IPC, of course, with the gloved hands all the way. We should carry out all these processes, okay? And then we don't collect stool specimens from a toilet bowl or a bedpan, okay? Because that will not be representative. Those might have, parasitic forms from previous samples or other people's samples, which, can give us a false positive report. And of course, we don't want to have chemicals in the urine, okay? Especially when we're going to do chemical analysis, and they could interfere. Great. So macroscopy, the basic things to look out for are the consistency. Now, when you have very well-formed stool, you're not likely to have pathogenic organisms present in it. But the more fluid the stool is, the more likely there is a pathogen in it. Okay, we know normal urine, it appears about brown, brown color and quite formed, or just slightly semi-formed in adults, and in children, it can range towards yellow-green and tends to be quite less formed. Okay, so other colors like appearances of black urine, obvious blood in urine, obvious pus in urine, and mucus are indicators that there is some pathogenic process going on. Particularly with bacterial infections, you tend to have pus and mucus. Blood is present when you have invasive microorganisms being implicated. So with Entamoeba histolytica, for example, you tend to have blood in your urine. With bacillary dysentery caused by Shigella dysenteria, Salmonella infections, Campylobacter species being implicated, you could have pus present in the stool. Okay, there could be gross worms, even though this is becoming more and more less common because of the wide use of anti-helminthic therapies. you could actually have gross worms present in stool, and you can have segments of worms. For example, the tapeworms, they're segmented flatworms. So their proglottids, as they mature, can fall off, and be found in the stool, lined away from the adult worm. Okay, so all of these give an indication of the possible pathology. Okay? And then, of course, the microscopy goes on to examine it under the microscope using either of these wet preparations here. You can do a saline mount where a drop of, okay, I'll go on to describe this process later. You can perform an iodine mount. Both actually basically the same. It's just that the iodine mount helps to better outline the parasitic forms that might be present in your stool so that you can visualize them better. And then a methylene blue mount is actually done to identify the presence of leukocytes within the feces. And that basically helps, in conditions where you have dysentery. So you want to know if it's an amoebic parasitic dysentery or bacillary, okay? Because the amoebae rather tend to have, as part of their pathologic processes, have a contact-dependent lysis of white blood cells. So there's usually a dearth of white cells in such samples. But with bacillary dysentery, you have a preponderance of white cells, and so on. So that helps with that differentiation. So what's required? Glass slides, cover slips, normal saline, iodine, a stick, bamboo stick, or just a broomstick would do to help with emulsification of the stool sample, for evenness before a portion of it is collected for examination. And then our light microscope, okay? So this is the process, okay? So for economy, just on one slide, a drop of normal saline is placed on one end and a drop of iodine on the other end. And then, of course, after emulsifying your stool specimen properly, using to emulsify into normal saline and thereafter into iodine, cover with a slip, and examine under the microscope, okay? And then look out for various parasitic forms. So you can have motor ultraphozoites of amoebic Entamoeba histolytica. And it's important to know that if you need to make it that, if you strongly suspect amoebic dysentery, you should examine your specimen as soon as it's collected, preferably within 30 minutes, because thereafter, these trophozoites, which are usually motile, the actively motile and destructive forms, tend, to get you can easily miss them. They begin to look like pustles and so on, and so they can easily be missed. Okay, so the earlier when you suspect these conditions, the earlier you examine the specimen, the better your likelihood of identifying it. Okay, motile trophozoites of Giardia lamblia as well, they lose their motility over time and would not be observed thereafter. So you examine that abruptly. Then, of course, larvae of Strongyloides. Strongyloides stercoralis is one parasite that has eggs that are quite similar with hookworms, but they don't pass their eggs in stool. Okay, so when you see those eggs that looks like Strongyloides or hookworm eggs in stool, most likely it's a hookworm infection. And then you find the larvae forms, which are also similar between both organisms in stool. That likely is Strongyloides stercoralis infections. And then, of course, a variety of various eggs and cysts. And again, these cannot be done without a good atlas. Of course, with experience, you get used to the appearances. But if you have a good atlas handy, you can easily identify, and make quick decisions about your patient. Of course, you're advised to still send your samples to the laboratory for confirmation and further analysis to help, give a definitive diagnosis. Okay, so down here we have an iodine mount. You see it's brownish, everything is brownish, and the parasite form is more visible, well outlined. And this is a saline mount. It actually looks more clear, ground glass, sort of, so it might not be so visible to the untrained eyes. Okay, but the iodine helps to make that better observed. Methylene blue stain is also very easily done, just involves using the methylene blue dye rather than iodine or normal saline. Okay, and then it stains the leukocytes. And over here, you can see the nucleocytes, right? So you see a unilobed one down here, and then you have a multi-lobed cell here and over here. okay, over here. So that shows you there are multiple leukocytes present on this smear. And so that, of course, could help you decide between a bacillary and an amoebic dysentery. Okay, and that can help take a quick decision with your antibiotics, take a quick decision on various other interventions, you know, that can be done. Thank you. These are my references, and I want to see a big thank you for listening. Over to you, Dr.
Thank you very much.
Thank you very much. Thank you so much, Ma, for that wonderful lecture. And you really made it look so simple, and we are grateful. Is there anybody that has a question? If you have a question, please, you can quickly ask. I will take one or two. We'll take one or two questions, and the remaining questions will be sent to the WhatsApp, the Telegram group. If you have a question, you can raise up your hand. Let me read some questions from the chat box. Thank you very much, Prof. Okay, let me read some questions from the chat box now. Someone asked, what are the changes that can affect urine analysis? What are the questions that can affect urine analysis if the analysis is done after 1 hour? That is one of the questions from the chat box. Can you hear me, ma?
Yes, I can. Thank you for that question. So of course, on standing, okay, a lot of changes can occur with urine. So
did you get the question?
Sorry?
Okay.
Yes, I did. I got the question. Okay, what changes can occur in urine when it stands for about an hour? Right? Great. So various changes can occur, okay? Of course, with long standing, the number of organisms, remember, urine is not a sterile sample. Usually urine comes through the urinary tracts, through the urethra, and you know, it's collected, you know, and those areas, the lower urethra is not sterile. There could be various contaminants from the pelvic region, the anal region there. So you are likely to have some amount of organisms in any urine sample, okay? And that's why when we're doing a culture, we have a minimum benchmark, which we call significant bacteriuria, to make a diagnosis of a urinary tract infection. So those organisms will multiply, okay? The number will increase, okay? And that can affect various components of the urine. The acidity of the urine could also increase, okay, depending on the activity of the organisms contained within it, okay? So of course, turbidity can change. The degree of turbidity of the urine can increase over time, okay? Urine smell will change, of course, because of the ketones and various other metabolic products of the organisms, you know, going on in the urine, okay? You can have crystals, you know, popping up because of the change in pH in the urine. So if there was calcium in the urine, it can begin to crystallize more. So you have lots of glossy, shiny calcium oxalate crystals present, you know, and various other crystals, depending on what drugs or foods and you know, things the patient had been on before he passed that urine. So all those can happen, okay, basically as urine stands. So it's advised that if there's going to be a delay in examining urine, you should refrigerate it. Okay, you should refrigerate it for short periods before you examine, so that you don't have it change drastically and not become representative of your patient anymore.
Okay, ma. Thank you, ma. Someone is raising a hand. Aisha Ahmad. Aisha, you can unmute yourself and ask a question.
Okay, good morning, Ma. Thank you, Ma, for the beautiful lecture. Please, I just wanted to ask what is the difference between, the relationship between specific gravity and proteinuria in terms of translating it as significant proteinuria, specific gravity proteinuria parameters. Hello, Ma.
Yes, I can hear you. Yeah, thank you for the question.
Okay, thank you.
So usually there is there could be some amount of, there is some amount of protein in urine, okay? But of course, with renal pathologies, the quantity increases, okay? So usually your dipstick measures that grading. Specific gravity is not caused only by the presence of protein in urine, okay? Various other constituents of urine can give it that, specific gravity, not just protein, okay? So the degree of proteinuria increases, with your pathology. For example, in nephrotic syndrome, we have large amounts of urine present in this, large amounts of protein rather present in urine, and that can help with diagnosis. But note that it is not just the presence of protein in urine that gives it a specific gravity. The constituents, the constituents, various other molecular constituents add up to its specific gravity.
But please, I don't know if we can look at it in respect of preeclampsia. Like for some of our patients with 1+ proteinuria, they usually say we should look at the specific gravity, that there is a value of specific gravity that will tell us even the 1+ if it's significant proteinuria, but I've never understood that range. That's what I'm trying to, yeah.
Okay, so I guess that would, yeah, I guess that would mean relating it to the normal specific gravity of urine, right? Okay,
yes,
so normally, yes, normally urine has a specific gravity somewhere between 1.010 and 1.030. Okay, you would usually find it about 1.010 to 1.020 or 25. Okay, but it can go as far as 0.030. That's 1010 to 1030, so to say. Okay, when you have a much higher than that, it shows that the specific gravity is much higher. Okay, and of course the presence of protein in urine shows a defect in the reabsorptive capacity, right? So protein spills over into the urine, so to say, right? Right. So the more it is in the bloodstream, the more it spills over into the urine and gives you the higher SG.
Okay, so that means the more the protein in urine, the more it will affect the specific gravity. The specific gravity will go up?
Certainly.
Okay, thank you very much, Ma. Thank you for the opportunity. Thank you for the lecture.
Thank you. Thank you.
Thank you very much, Ma. There's one more question, and I'm actually also interested in the answer to this. As a pediatrician, I say I will do urinalysis and you get ascorbic acid ++ or 2+. What is the relevance and the interpretation of ascorbic acid in urine? What is the clinical relevance?
Well, ascorbic acid we know is vitamin C, okay? So that just shows you that your patient has been taking, progressively, well, depending on the amount, the patient has been taking some vitamin C. So of course, the more they take, the more you have present in your urine. So it's really, it's a water-soluble vitamin. It will be passed out, okay? It really has no, we know that vitamin C being water-soluble is actually quite safe to a large limit. Quite large doses can be taken and still be safe because the body, can deal with it. In one of the ways is by, secreting it in urine. So it doesn't have any major clinical implication. You might just want to ask your patient to cut down if they're reprobe and see if they're doing unnecessarily high doses of vitamin C. You might want to ask them to tone down and stay within limits, okay? So they don't abuse and cause issues. Okay.
Thank you very much, ma'am. We are very grateful. It was a very clear, straight to the point presentation. Someone just asked a question. What does ketone in urine signify in a patient that is not diabetic?
Okay, so ketones are also quite elevated in extreme starvation or large periods of starvation. So if you could have patients who have been fasting for very long periods, being off food for long periods, they will have ketones in their urine, and sometimes you can even smell it on their breath. Okay, so it can be seen in extreme starvation.
Thank you so much.
You're welcome. Thank you.
We are going
Pastor.
to
We have one in our
call on
center
the
now. Louis now. All these online classes, but all these online classes, I see him there.
You need to mute everyone.
Oh, one hand, they sent me back. I had to quickly call their rata. Said this guy is not yet a second initiate. I registered it, he's not a second initiate. To the best of my knowledge.
Can you mute everyone? Host, please? Can I do that?
That was what I did beat you. They sent him out. In short, later they took him and kept posting the class. Because that rata might not know.
Okay, Wema, please, can you mute? Thank you.
Okay. Thank you so much, Ma, for the lecture. Prof, that was a very clear and interesting question. And I look forward to going back to looking at the slides, which we are going to get later. I'm going to call on the third speaker, Dr. Augustina Isioma Ikusemero. She's going to tell us about PCV. She will tell us about PCV and blood smears. She will tell us about thick and thin film, blood group, ABO, and resource factor. Let me tell us a little about our speaker. Dr. Augustina Isioma Ikusemero. She's from Anyosha North Local Government of Delta State. She was born on August 27th in the early 70s, the first of 8 children. She attended St. Louis Primary School, Kano State, and proceeded to Federal Government Girls College, Kazaure, then Kano State, but now Jigawa State. Then to Ahmadu Bello University, Zaria, Kaduna, where she had her MBBS. She proceeded to the University of Benin Teaching Hospital for internship training and residency training, respectively. She became a fellow of the National Postgraduate Medical College in the Faculty of Pathology in 2012, so specializing in hematology and blood transfusion. She was appointed as a consultant in the Delta State University Teaching Hospital. She is also the founder and the CEO of Safe Blood for Nigeria Foundation, an organization that is aimed at ensuring availability of safe blood and blood products through voluntary, non-remunerated blood donation. She is married and blessed with 2 beautiful daughters. Welcome, Ma, to this presentation. Let me get our slides for sharing.
Thank you very much, Dr. Nadi. I'm so grateful for this opportunity to participate in this CME program. And I must also thank the National President, Dr. Seji, and the 2 previous presenters, Dr. Modupe. That was a wonderful presentation. In fact, I'm truly inspired. And Professor, you also did a good job. Thank you very much. Good afternoon, everyone. So I'll just wait for my slides to be shared by the host, and then I'll proceed.
Hello?
Basically, I hope you are hearing me all. I'm loud enough. Now, basically, I'll be talking about hands-on. I'll be talking about hematological investigations that are very important to us, standard operating procedures. Okay, so today I'll be talking on the packed cell volume, which is also known as the hematocrits. I'll proceed to talk about blood smears, taking into consideration the thin and the thick blood smears. And then finally, I'll round up the discussion with the ABO and resource factors. Now, starting with the packed cell volume and the hematocrits. I'll briefly define it. I'll talk about the methods that I used, the requirements. I will elaborate on the procedures, the normal ranges, the sources of error, and the clinical significance. On the clinical significance, I see that Dr. Modupe has thoroughly elaborated on that. So I'll just mention it as I go on with the presentation. Now, briefly, the packed cell volume and the hematocrit is truly the amount of red blood cells in a given sample of blood after centrifugation, expressed in percentage of the total volume of blood sample. Okay, you know, the red blood cells, they have this capacity to deliver oxygen to tissues. And so it's very important that we have them in adequate amounts in our body. And the packed cell volume and the hematocrits are the most commonly investigated samples or requested by clinicians in most facilities. Okay, so they are actually, you know, they are done in the side lab. So it's important for us to know bits and the step-by-step process of conducting this blood test, because this blood test can actually save a life. The results from this test can actually save a life. And that's because, again, because apart from the fact that it's widely requested for, it is also cheap, cost effective, it is simple, and the results are readily available. We will get an instant result. Now, there are two methods of doing this, or conducting this investigation. We have the microhematocrit using the capillary tube, and then the macrohematocrit using the Winthrop tube. Now, the one that is commonly done in our environment is the microhematocrit using the capillary tube. I guess, again, because it is cheap, it requires little volume of blood to conduct it, and the result is also very readily available. Now, the macrohematocrit using the Winthrop tube is quite expensive. The volume of blood required is quite much, and it's cumbersome a bit. And although the tube is calibrated, which is of course different from the microhematocrit capillary tube, which is just a tube, a slim tube and very small, and contains very small quantity of blood. Because you can imagine a patient who is anemic and you have to use the Winthrop, okay, to consume a large volume of blood. So we tend to perform the microhematocrit using the capillary tube more often. Now, what are the requirements? Okay, these are things you require in order to have this investigation done. You need small capillary tubes, okay, about 7 mm long and 1 mm uniform bowl. That's the round diameter at the end of the tube. Now, the capillary tube here can be heparinized or non-heparinized, okay? The heparinized capillary tube, the heparin there is like an anticoagulant that keeps the blood fluid in the tube. Now, if you have to use the non-heparinized, you're going to use it in an EDTA. You are going to use the non-heparinized capillary tube to express blood from an EDTA container containing the blood. Then you require the special centrifuge, which is the microhematocrit centrifuge, a plasticine, and then hematocrit reader, and of course, blood sample in an EDTA bottle. Now, the procedure. Now, the procedure is very important here, and I want us to pay attention to this. You know, for those conducting this test and have the privilege of having the patient with them to collect sample from this patient in the side lab, it's important for you to identify this patient, okay? Make sure you do proper labeling to prevent error, okay? And then you must assure this patient and explain to this patient the type of test you want to conduct on him or her. So with such patients, after all this done, you will take the patient, either the middle finger, the pulp of the middle finger, or the pulp of the big finger, okay? And then you clean thoroughly with a cotton wool laden with methylated spirits. And then you puncture with a sterile lancet. Note, as soon as you puncture, please, the first drop expressed should be wiped away. I will tell you why as I progress in this discussion. And then with the subsequent drop, you express blood into the heparinized capillary tube to about 2/3, okay? And then at the end of the tube, you would use a plasticine or a molding clay, or even a seal, or you can even seal with flame, but we kind of discouraging people from sealing with flame because not everybody can do it. Some of them, sometimes this flame can go ahead to destroy this red cell. So we don't even encourage that. We encourage that people use plasticine or a molding clay to seal properly. And you must actually seal properly to prevent spillage during centrifugation. Now, I recommend also that at least you use 2 capillary tubes at a time. In case one gets spilled out, you can actually have the other one to make use of. Now, the tubes are placed in a radial groove of a centrifuge. That's a microhematocrit centrifuge. And then the centrifuge, centrifuge at a speed of 10,000 to 12,000 resolution per minute for about 5 minutes. At completion, the tube are then taken out from the groove of the microhematocrit centrifuge and read using a microhematocrit reader, okay? A microhematocrit designed for the purpose. Now, the length, that hematocrit reader is what actually reads the capillary tube. That's why it's called a microhematocrit reader. It has been, it was done for that purpose. So the length of the packed red cell when placed in the reader is of interest and it is expressed in percentage. Okay, so it's of interest and it is expressed in percentage. Okay, now these are the normal ranges. The normal ranges differ with sex, age, and geographical location. Now, for the male, we are looking at between 42 to 52%. This is normal. For the female, 37 to 47% normal. And at birth, we are looking at 44 to 62%, which is normal. I want you to also note as well that if you already have the knowledge of the hemoglobin concentration as expressed in gram per DL, the packed cell volume can be determined by multiplying the hemoglobin concentration by 3 and you get the packed cell volume expressed in percentage. So that's another way you can actually determine the packed cell volume. For instance, if you have the hemoglobin concentration of the patient available. Now, these are some of the sources of errors you may experience while conducting this procedure. Now, make sure that, like I said earlier, make sure that you always wipe away the first drop obtained following puncture of the finger. Why is it that? You must know this. It's because that particular drop contains interstitial fluid, and that can give you a false result. So it's important to wipe the first drop, and then use the next subsequent drops that you express. Now, avoid excess squeezing or pressure on the finger to enable blood flow. Why? Because this will hasten clotting. So when you are trying to express the blood from the finger, please apply gentle pressure, because if you apply very intense pressure, you might end up hastening clotting, facilitating clotting, and that might give a false result as well. Now, if using blood from an EDTA sample, meaning for those not having the patient around them but have the sample with them, okay, ensure that when collecting the sample from the patient, ensure that the sample is up to 2.5 mils, okay, 2.5 mils of blood collected with the syringe and transferred into the EDTA bottle is actually adequate to perform the packed cell volume. Now, this is because if the sample is inadequate, the packed cell volume value will be very low, and this because the red cells will shrink. Now, storing a sample meant for packed cell beyond 6 to 8 hours will result in a false result. So for accurate results, it's important that we conduct the test immediately, because I noticed that some persons will collect sample with an EDTA and store it. In fact, some of them, they decide to pull sample before they conduct a PCR test on it. That's wrong. So please, we should always ensure that as soon as we collect the sample, we should conduct the test immediately, not beyond 6 to 8 hours. Okay, instead, if you do that, you get a false result. Now, heparinized capillary tube should be stored in a cool place, not a hot climate, because hot climate deteriorates the heparin. So if you are using a heparinized capillary tube, it's expected that you store it properly in a cool environment. Otherwise, you'll be having wrong results. A cloth in a sample can be a source of error. So always check your sample and ensure that there are no cloths in it. Then inadequate mixing of blood sample before the test gives an error in the result. So you must mix your sample adequately. A short duration and low speed centrifugation may not achieve as complete packing as possible. So always ensure that your equipment are optimally working. Okay, because if they are not working, they can affect the results. Hematocrit tubes should be read as soon as centrifugation is completed. Otherwise, the plasma will be evaporated and this may give a false result. Truly. So as soon as you get your result, I noticed that some people leave the capillary to improve of microcentrifuge for a long time. Some people leave it there to the next day. Okay, I don't know why they do that. That's an observation. Okay, and that's not good enough because the plasma will evaporate and this may also give a false result. So it's important we take these things into consideration and do them properly. Now, what are the clinical significance? Yes, the clinical significance here I'm going to talk about is what are the conditions that will give you a low packed cell volume. Yes, Dr. Mudupe actually elaborated on this. Okay, now I listed them here, but I'm not going to really expatiate on that. It has been previously discussed by Dr. Mudupe. Anemia, of course, anemia here we're talking about a bone marrow suppression, isolated red cell suppression. Okay, then hemolysis, the breakdown of the red cell bleeding, pregnancy, talking about dilutional anemia with pregnancy, and then renal failure, erythropoietin not produced, and then nutritional deficiencies. Deficiencies in B12 and iron can give rise to anemia, a low packed cell volume. Then for conditions that can give you a high packed cell volume, we're talking about polycythemia. Polycythemia, of course, maybe in the presence of tumors that produce a lot of EPO, that's erythropoietin, and this will stimulate the bone marrow to produce more of the red blood cells, and you see a lot of them in the system as polycythemia. Dehydration, patient has lost blood, you have hemoconcentration, and then to give you a false result of the high PCV. Lung disease, smoking, high altitude, this will create a hypoxic environment that will stimulate the kidneys to produce erythropoietin, and then will give you high PCV. Now, this slide that shows the picture of that demonstrate the content after that demonstrate the heparinized capillary tube after centrifugation. Now you can see from this picture, yes, from this next slide, please, Dr. Nod. This picture, this pictogram, you can see from this pictogram that the capillary tube, you would see the red cells properly packed down there, okay, and expressed or measured as 42% at that level, okay, and then between the red cells and the plasma is the white blood cells that we refer to as the buffy coat. Now the buffy coat contains the white cells and the platelets, okay. Above the buffy coat is a plasma. So the red cells, the packed cell volume is expressed in percentage, the amount of red cells expressed in percentage, okay, against the full the whole volume of blood, okay, expressed in 100% as depicted in this pictogram. Now I'll go to the next discussion where I'll be talking about the blood smear, thick and the thin blood smear. Now, the blood smears are simple procedures to perform, and the reason why it is performed is that it is aimed at demonstrating and acquiring information on the blood cells, quantitatively and qualitatively. Now, the quantitative importance enables the numbering of blood cells, while the qualitative function is to demonstrate and identify the cell morphology, including leukocytes, monocytes, red blood cells, and platelets. Now, this is very important because sometimes, you know, the automated hematology analyzer could give us a results for which we cannot actually, let's say, an undeterminate result. We are not sure of. So we can actually use the blood smear as a backup. Okay, so quantitatively looking at the blood film, you can actually count the number of white cells, platelets per high power field. Okay, and also it can also tell us, for instance, we're looking at hypersegmented neutrophils in megaloblastic anemias. Okay, you can actually count the number of lobes. It's expected that a normal white cell should have lobes between 3 to 5. When you begin to find lobes more than 5, okay, we are talking about hypersegmentation here. So quantitatively, you can use the blood smear to actually acquire information on the number of these blood cells. And then qualitatively demonstrate morphology. Okay, morphology is talking about the morphology of the red cells. For instance, in iron deficiency anemia, you find out that the reds are hypochromic, microcytic blood cells. Now, the thin blood cells, like I said earlier, demonstrates and differentiates leukocytes and the blood abnormalities, example, anemia, etc. And the thick blood smear is for the diagnosis of blood protozoan parasites. Example, if you want to demonstrate the ring forms of malaria parasites, etc. Now, what are the requirements? What are the things you need to conduct a thin and a thin blood smear? Now, you need, Dr. Nodi, please, can you move the slide? I'm talking about the blood smears now. Just move it to the blood smears. Okay, I'm in the slide talking about the requirements, please. Now, the requirements include a sterile syringe and needle, an EDTA sample bottle, a tourniquet, a pen marker or a label, and then a sterile lancet, a microscopic glass slide, a microscope with an immersion oil, 70% isopropyl alcohol, and then the Romanostic stain. You know, this differs in labs. Some labs will use the Genscher, and some labs will make use of the Leishman stain. Now, the Romanostic stain is the most important stain that is used in hematological investigations. The reason is because the Romanostic stain is a neutral stain, is a dye. Okay, it has the basic component and it has the acidic component. Now, the basic component consists of the the acidic component is the eosine dye. Okay, and then the basic component is the methylene blue. Now, how is it demonstrated when you use it to stain a blood smear? Now, the eosine is attracted to the alkaline aspect of the cell, which is the cytoplasm. So it stains it reddish. Okay, that is why when you look at the blood film, the red cells are stained reddish. They'll actually pick up the eosine component of the Romanostic stain. And then the methylene blue, they stain the acidic aspect of the cells. That's the nuclear details. Okay, that's why those ones stain bluish purple. Okay, so it's very important. Now, there are other components of the Romanostic stain. Apart from the Genscher and the Leishman, we have the Jenner stain and then the May-Growald stain. These are the other stains, the Wright stains, and so on and so forth. Now, the procedure. This slide, please go over to the slide that shows the procedure, the step-by-step procedure for the, that's the next slide, please, Dr. Nodi. Now, this slide shows the step-by-step procedure. Like I always say, when you want to conduct an investigation in a patient that is standing just before you, it's important for you to identify this patient, okay, proper identification and proper labeling to prevent error, okay, and then you have to assure this patient and then explain to this patient exactly what you want to do. It's very important. This kind of calm this patient down, and sometimes they cooperate with you. Okay, so after doing that, the next thing to do is then you lift the third finger. Okay, you lift it up with cotton wool laden methylated spirit. You wipe properly, and then use a sterile lancet to puncture the pulp of the middle finger, and then you express the first drop of blood. Then the subsequent drop, you will get a glass slide, okay? Now on this glass slide, you express like 2 to 3 drops on the glass slide that you want to use to make the thick smear, and then express just 1 drop, okay, on the same glass slide as demonstrated here, that you want to use to make this thin smear. Now, having done that, the next thing is to get a spreader. You know? Now the spreader you place in between the 2 to 3 drops of red cells and the red cells you want to use for the thin smear. You place it in between at an angle of 45 degrees, and then you spread. Okay, that's the thin blood smear you have just done. And then with the same spreader, at the tip of the same spreader, you will use it on those 2 to 3 drops of red cells you collected. You will just spread it, you know, on the larger drop, you know, spread them to make a thick smear, okay, just as it is demonstrated on this slide, okay. After which you would use a pen or a marker to label it properly. Now the next slide shows you exactly what we have just done, okay, the thin film and the thick film. Now, having done this, for the thin film, you will need to fix it. Now, we usually fix it using methanol. Sometimes we can drop methanol over it, or we dip into a container containing methanol, okay, to fix the thin blood smear, while the thick blood smear is allowed to dry. Now, having done that, okay, you take it to a staining rack where you will now use your Romanowski stain, depending on the one you're using. Some people use the Gemsha and some use Leishman, so it depends on laboratory. Now you would place the slide on the staining rack and then cover the slides with the stain. Totally, you have to cover it totally with the stain poured over the slide for 30 to 40 minutes. After that, then you place the slide under the running tap gently to wash off the excess stain. Allow the slide to dry and then you view under the microscope with an emulsion oil using ×10 magnification ultimately. Now you can begin from ×100, sorry. Now you can begin from ×10 magnification, you upgrade to ×40, and ultimately you use ×100 magnification, and this will demonstrate exactly what you are looking for. Now for the thick blood smear, like I said earlier, this demonstrates malaria parasites. As shown here, you can see the malaria parasite within the red blood cells. They're properly demonstrated here. Now for the thin blood smear, this demonstrates the morphology of the red cells, okay? This is an example. This is a film showing iron deficiency anemia. You can see the microcytic red cells with a large central area of pallor, and then anisocolicocytosis, pencil-shaped cells. And then also it's showing us a lymphoid cell here, it was a little bit cleaved at the center. Okay, also the platelets are demonstrated here. Now the next slide is same thing with the next slide. This is a normal blood film, so to speak, showing us a segmented neutrophil containing 3 lobes, and then the band form of a neutrophil, and then the central pallor of the red cells. So this is what you would see under the microscope at the end of this procedure. Now this brings us to the end of the thin and the blood and the thick blood smear. Now we are going to talk about the ABO and the resource factor. The ABO and resource factor is very, 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 very important clinically. In fact, it's although very technical, it's the ABO blood group system was first given by Karl Landsteiner in 1901, and it is based on the presence of antigen A and antigen B over the surface of the red blood cell. And phenotypically, we have 4 types of blood groups phenotypically. Now we have the type A, the type B, the type AB, and the type O. Okay. Now, genotypically, we have 6 types. Now, genotypically, we have type A, type AA, type AA, type AO, then type BB, type BO, then type AB stands on its own, and then type O also stands. That the importance of this genotypical expression of this blood type is when you want to determine the blood type of an offspring. So it enables you to cross-link, from both patients, but depending on the pattern of expression. Some express in a heterozygous pattern, and some of these types are expressed in homozygous pattern of expression. Now, it is natural that the red cells, the antigen over the red cells actually serves as markers, okay? They're like identifying the red cells. And it is not natural that in the presence of an antigen, okay, the body usually will produce an antibody. Now, for the type A individual, okay, having the A antigen over their red cell, okay, now the body generates an antibody. The body would not generate an antibody that would act against the antigen. That will mean that the body will destroy itself. But of course, an antibody has to be generated in the presence of an antigen. So what the body does is this. The body generates an antibody that is not attracted to the antigen, and then it names it type B antibody, okay? That's antibody B, such that the antigen and the antibody, they live amicably. That is why individuals with blood group A, with A antigen over the surface of the red cell, usually we express antibody B in their plasma, and they are comfortable with that. There is no reaction, and that's it. They are living very well. They are enjoying themselves. Now, that applies to type B blood group individuals as well. They have the type B antigen around the surface of the red cells, and the body sees it as an antigen. But instead of producing anti-B, of course, that would mean destroying itself. It would produce an antibody and name it a type A antibody or antibody A expressed in the plasma that is not attracted to the antigen. That is why individuals with type B blood group usually would have the anti-A in their plasma, okay? So that's how it goes. Now, for the individual with AB antigen, okay? Now, they have the AB antigen expressed at the surface of their red cell. Now, the body says, no, if I produce an antibody against this antigen, it will destroy cell. Now, if you know that, if you remember, I said that individual with antigen A has antibody B, and individual with antigen B has antibody A. So if the body decides to produce an antibody, it will cancel out. That is why individuals with antigen A and B at the surface of their red cell do not have antibodies in their plasma. Okay, because even if the body decides to produce an antibody, it just cancels out. Okay, so they don't have an antibody in their plasma. Now, going to individuals with type O and type O blood group, these individuals do not have antigen on the surface of their red cells. But yes, those type O individuals who are resource positive, I'll talk about the resource factors as we progress. Now, having the right resource factor are known as resource positive. And that's because they have the antigen D. Now, because they have the antigen D, the body, in the presence of that particular antigen D, okay, the body will now decide, okay, now there's an antigen. I want to generate antibody. Now, the body will not generate an antibody that would attack that antigen. But of course, there has to be an antibody. So it will generate an antibody and call it anti-A and anti-B antibody in the plasma of such individual. That is why individuals with blood group O, they do not have antigen, okay? I'm talking about those with resource positive antigen D in the surface of the red cell. Now they have antibodies, okay, in their plasma. Now, those with resource negative blood groups, they do not have antigen, okay, they don't have antigen D in the surface of the, they are not expressed, the resource factor is not expressed. Let's say the resource factor is not expressed. And because the resource factor is not expressed, they do not have antigen in plasma. They do not have antibodies in plasma. And so that is why they are referred to as what? The true universal donor. They can donate their blood to any blood type. That is why they are commonly used in emergency situation. Okay, you just if there's O negative blood in the blood bank, please, even without doing any laboratory work on it, it can be used. You'll be sure that there will be no transfusion reaction with such blood because they lack antigen and they also lack antibodies in their plasma. So that's the basis of that. Now, the next slide is a pictogram demonstrating this various, it's just a pictogram of everything I have talked about. Okay, the next slide. You see the blood group A, antigen around the red blood cell. And this is for the blood group A individual and expressing the antibody B in plasma. Blood group B having the B antigen around the red blood cell, expressing antibody A in the plasma. And then the blood group AB has both antigen A and B and do not have antibodies. And that is why they refer to them as universal recipients. Okay, they collect blood from every other blood type and they're home and dry because they do not have any antibody within their plasma that could attack the red cells. So that is why they refer to them as universal receptor. And then the O blood group, sorry, is not properly shown here, but I can explain it. Now, the last blood group here is group O, blood type, okay? This, because it has anti-A and anti-B in plasma, it expresses the rhesus factor, okay, which is the D antigen over its surface. Okay, so this is a blood group O with rhesus positive antigen or rhesus factor present. Okay, then let's go on to the next slide. Now, this next slide just demonstrates the blood type ensuring a compatible blood transfusion. Here. Now, if you look at this pictogram critically, you find out that a blood group A donor can only donate blood to a recipient who is also having a type A blood group. Okay, and also to the recipient who is AB. So blood group A individual can give to the individuals having their own type of blood group, and then AB, those having the AB type, the AB antigen, as depicted here by this arrow. You see the arrow pointing to A and the arrow pointing to AB. Likewise, blood type B individuals will donate to B individuals. And of course, I've explained the reason why all this happens. And then also to AB. And then the blood type AB individuals expressing the A and B antigen, okay, would give blood only to themselves. They only give blood to themselves, but they receive from everybody. That's how it goes. Okay, you can see all the arrow pointing to AB. So AB are the universal recipients. They receive blood from all blood types. Okay, now the blood group type O individual, okay, if you look at how the arrow goes, it gives blood to all blood types. Okay, now not putting into consideration the rhesus factor. Okay, now if you put into consideration the rhesus factor, okay, the rhesus positive individuals will not be able to give blood to rhesus negative individuals. Okay, if you put into consideration the rhesus type, but the rhesus negative individuals can give blood to all types. So they are the overall universal donors because they lack antigen and they lack antibody in their plasma. Now let's go to the next slide. This next slide demonstrates agglutination in the various blood types. Now this is showing us when we have a known antibody or antisera with an unknown cell. For instance, you want to type a patient to determine a patient's blood group, for instance. Okay, you collect the sample that is the red cell is unknown, and you want to type to determine the blood group of such an individual. also it's very important in when you are doing compatibility testing, okay, to ensure a compatible blood transfusion. Okay, now, if you look at the first panel of cells, the O positive cells, okay, now the O positive cells, there's agglutination. Agglutination is a reaction when the antibodies react. Okay, the endpoint is a reaction which we refer to as the agglutination reaction. Now, that's an anti-D. Okay, now there's in the first panel, that's an anti-D. There's a reaction, okay, with the O positive cells. That is because these O positive cells expressed the rhesus factor D. So there's an anti-D against that antigen, that rhesus positive factor, that rhesus factor which is D antigen over the red cell of this individual with type O blood group. So that's why there's an agglutination there. So with this, it tells you that this individual is O rhesus positive. Now the next one, O rhesus negative. You see, if you look at the next panel of cells, there are no agglutination, no reaction. Okay, that's because this individual is not expressing that rhesus factor over the red cell. And that's how it goes. A positive. Now for A positive, now the A positive individual expresses both the A antigen and the rhesus factor antigen. That's antigen D. So that is why you can find agglutination in anti-A and then anti-D. So this will tell you that this individual is A rhesus positive because agglutination is demonstrated on both sides. And this is how you go, and then so we'll get to the AB. Okay, the AB demonstrating agglutination in anti-A and anti-B panels. Okay, so that's how it goes. Now, the next slide is the rhesus factor demonstrating the heterogeneous pattern of the rhesus factor. Now, this is a father who is rhesus positive and a mother who is also rhesus positive. But in this case, they're expressing the alleles in the heterogeneous pattern, okay, of expression, such that the big D is dominant, and that's why it is rhesus, the father is rhesus positive, and the small d is recessive. The mother also has the big D dominant, and then the small d is recessive. So the mother is rhesus positive, the father is rhesus positive. Now, cross-linking, you find out that 75% of the offspring generated from this union are rhesus positive children. And then just about 25% will be rhesus negative. Recently, a father walked up to a doctor and was telling the doctor that he noticed that he just did the blood type of one of his child, and he discovered that the child is rhesus negative, but he is rhesus positive and the wife is rhesus positive, that he does not understand why it's like that the doctor should explain. So this is just exactly what happened, okay? It is clear that they both have the rhesus negative antigen that is expressed in the recessive pattern here. So it can be demonstrated in one of the children. Okay, that's exactly what happened. So it's not something that they should worry about. Now, the significance of the rhesus factor is also very important, especially when we are talking about or dealing with hemolytic disease of the newborn. Now, in hemolytic disease of the newborn is when a rhesus negative mother, okay, marries a rhesus positive man, okay, and then she happens to be carrying a pregnancy with a rhesus positive baby, okay? Now, in the first pregnancy, during parturition, there's a tendency that there will be a blood spill from the baby to the mother's circulation. Remember, the baby is rhesus positive. Now, when this happens, okay, the mother becomes sensitized, because yes, becomes sensitized, okay? And when she becomes sensitized, okay, because now a rhesus positive blood has mixed up with the mother's blood, and then the immune system recognizes as an antigen and then triggers antibody production, sensitizing this mother, okay? Now, there will be no problem at first pregnancy. Subsequent pregnancy, okay? If, for instance, if history is not obtained and the mother was not giving Rogan during the course of the pregnancy, or maybe the mother does not understand, or maybe an illiterate mother and then didn't give such a history, and then maybe during parturition again, okay, this mother's blood can spill into the baby's circulation and begin to destroy the antibodies now that was produced during the first pregnancy, okay, can spill into the baby's circulation and then begin to destroy the baby's red cell in subsequent pregnancy. So to prevent hemolytic disease of the newborn, it's better prevented. And how do you prevent? By taking adequate history, identifying this the rhesus factors in both the mother and the father, and then give Rogan during the course of subsequent pregnancy. Now, the last slide, I just want to quickly take us on some questions, just like a vignette or something. Now, one is this: what will be the blood group of the offspring of a AB rhesus positive father and O rhesus positive mother? What do you think will be the blood group of the children or the offspring from this union? I don't know if somebody can unmute and just tell me. I would appreciate that. Otherwise, I will give the answer to it. Okay. Okay, let me just go ahead and give the answer. The answer is this: the offspring will have either the A or the B blood type. Okay. Now, phenotypically, A and B blood type. But genotypically, it will be AA, AO. But the O is expressed in a recessive pattern. Okay. BB and BO. So BO is regarded as B blood type. AO is regarded as A blood type. So the offspring of this union will produce children with A type and B type only, phenotypically. Okay. Now, the second question: what will be the blood group of the offspring of B rhesus positive mother and AB rhesus positive father? Okay. Now, the blood types here will be A, B, and AB. So these are the blood types of the children from this union phenotypically. So at this point, I come to the end of my presentation. I hope with this you have at least understood ABO and rhesus grouping. Is very technical. A lot of persons get confused by it, but I'm sure I've been able to explain it and I've made it simple for every one of us. Thank you very much for this opportunity again. So I'm open to questions.
Thank you so much for that presentation, Dr. CME. That was a quite lucid presentation, straight to the point and easy to understand. Is there anybody that has a question? If you have a question, you can raise up your hand and we will. There's no right. If you have any question, let me read some questions from the chat box. Some people ask questions, so let me ask on their behalf. Someone said, please, ma, is it possible for an AA mother and an AA father to give birth to an SS or AS child? Is it possible?
Now we are talking about, now we are not talking about, now we are talking about genotype now, not blood group. We are shifting from blood group to the actual, the genotype of these patients, okay? So you said if it's possible that AA father, okay, marries what? AA mother,
okay,
and gives birth to what? AS child.
Well, let me quickly look at that. We have a lot of issues of paternity issues and problems with paternity. So I think that question is important, but okay, then I will now ask another question. from the sharp box. It says, why is the first drop of blood cleaned off? Does it matter that the finger is pricked? I think you explained it, but you can tell us more about it.
Yes, it's very important that the first drop of blood is wiped away because it contains interstitial fluid. And then if you express and pick sample from that blood, it will affect your results. Okay, so it's better you wipe it out, and then the next drop is what you should express. So that's the reason why it's important to wipe it away and use the next drop. It contains interstitial fluid and it will affect the results.
Okay, thank you. Our national president is raising her hand. I think you want to say something, Ma.
Yes, thank you.
Okay, Ma. Go ahead.
I have this hemoglobin scale by Kits, which I'm told is used in the field. And
Yes,
they have a blotting paper and they have red that they use to compare with the blood on the blotting paper. I want to find out, is it still relevant in today's work or it's obsolete?
I think it's obsolete. The reason is because, okay, you are using such you are not demonstrating the packed cell volume or hemoglobin concentration quantitatively. Okay, you are demonstrating it qualitatively. So that book shows the qualitative nature of the hemoglobin of the patient and comparing it to that demonstrated in that book. Okay, but it's important because sometimes it can be misleading. For instance, what if the patient is dehydrated? Okay, what if the donor, now we're talking about the donor now. Now, what if the donor is dehydrated and the donor comes to donate? I know with dehydration, you can have a hemo concentration, and then you express the blood from this dehydrated donor and compare it with the color as expressed or as demonstrated in the book. It can give you a misleading result. Okay, you think that this patient actually has a you may think that this donor is eligible to donate, but of course the donor is not eligible. The donor is just simply dehydrated. So I think I'll advise that it's much better if we determine hemoglobin or packed cell volume quantitatively. That will give us a better idea of the status of our donors. I hope that answers your question, ma'am.
Thank you. Yes, it does.
Thank you very much. And I can see Dr. Gloria Oladele. You can ask your question, unmute yourself and ask your question. Dr. Gloria Oladele, ask your question.
Good afternoon, everybody. I really want to appreciate Dr. Isoma for the wonderful presentation. My question, or rather, actually, I just want her to re-emphasize this clarification she made concerning the ability of a father and a mother to carry the heterogeneous traits of the rhesus factor D. Because way back in medical school, I still recall this common challenge that both parents are rhesus positive, and then a child is rhesus negative. And then the aspersion or assumption is that probably there was infidelity on the part of the mother somewhere along the line, So this particular explanation or illustration she made with that particular table on the heterogeneity of rhesus D trait being carried, she threw a very clear light on the fact that it is a possibility.
Yes.
If they both have, yes. So I want her to reemphasize that for us medical practitioners, so that when we counsel our patients, when we are confronted with these issues, just like the example she gave to, we'll be able to better throw light and educate our patients at the end of the day. Thank you.
Thank you very much. Dr. Nodi, please can you take us back to that slide, that particular slide she is referring to?
Let me open this line. Which of them? Do I go back?
And that's it. And that's it. Thank you very much, Dr. Nobu. Yes, if you look at this diagram, okay, that's the mother and that's the father. The father expressing the resource factor D, the big D, and the small d. Now, the small d is recessive and the big D is dominant. And that's what makes the mother resource positive. The big D also is dominant and the small d is recessive. Okay, that's what makes the father resource positive. Now, after conducting the cross linkage, you find that as explained here or as written here, 75% of the children are resource positive, while 25% will be resource negative, as demonstrated here. With the small d, that's the small d, expressing itself homogeneously. Yes, you know, that's the small d are expressed, okay, recessive though, but homogeneous in the homogeneous.
I think we have answered
Such
this.
cases.
We have Dr.
You
Aisha.
can actually explain to them based on this cross linkage. Now, if for instance, the mother is resource positive, okay, resource positive, yes, with a homogeneous pattern of expression of resource positive, that is having the big D, big D, big D, big D, big D. And then suddenly they come up to say that the child is resource negative. That would be an aberration. That's one you'll be thinking of as in infidelity, the case of infidelity. So resource factor is also very important in determining paternity disputes. It's one of the steps when conducting paternity testing. Okay, so that will establish the fact that having a resource positive mother and a resource positive father, okay, and a resource negative child. Yes, it is possible, but you can go further to do paternity testing. For instance, why you need for you to go further to do a paternity testing for such disputes is because that will establish the expression of the resource factor in both parents. Okay, it will go an extra mile to express the resource factor in those patients, the expression, the pattern of expression. Okay, so if during the paternity testing you find out that, oh, the mother expresses a homozygous pattern of expression with the big D. The father also expresses homozygous pattern of expression with the big D. Okay, then having a resource negative child in such cross linkage will be, it's questionable. So paternity testing will establish that. I hope this answers your question.
Thank you very much. Dr. Aisha, you have a question, Dr. Aisha. Unmute yourself and ask your question. Dr. Aisha, you are not here. Okay. Dr. Ngozi Nzekwe, Dr. Ngozi Iman Nzekwe, can you ask your question, ma'am?
Okay. Thank you very much.
Unmute yourself and ask your question.
Thank you. All protocols observed. You know, Dr. Ikosemoro said something about 75% of the children. I would think that is for each pregnancy, 75% chance of rhesus positive and 25% chance of rhesus negative. I don't know if.
Yes, that's what I mean. That's what I mean. It's a chance, it's a probability.
Yes, okay.
That's exactly what I mean. It's a probability. Yes. Some 5% chance of the children will be rhesus positive and 25% chance of having a rhesus negative child. Yes, for each pregnancy. That's
Okay.
right. Yes,
All
that's
right.
what
Thank
it
you
is.
very much. Thank you.
Okay. We have come to the end of this lecture by Dr. Augustina. Thank you so much, ma, for this presentation. We are going to call on our Dr. Ngozi. Do you still have a question? You're on the still raised. Are you done? I think you are okay.
I'm trying to put my hand down.
Okay. Okay, ma. I'm going to call on the third speaker, Dr. Ademola Ademoyin. Let me give us a few. Get ready to share your slides while I tell us about Dr. Ademola.
It's fourth speaker,
Yes,
number
okay,
4.
fourth speaker. Say sorry. I need to, Dr. Ademola is somebody I want to tell us about now. He is He's a specialist physician in clinical hematology, transfusion medicine, and laboratory medicine. He's very keen on policy systems in healthcare administration, and leveraging technologies to improve health outcomes. Dr. Ademola obtained his medical degree from the University of Lagos, UP Unilab, and completed postgraduate fellowship of the National Postgraduate Medical College Nigeria and the West African College of Physicians in 2016. Dr. Ademola was part of the bone marrow transplant program at the University of Benin Teaching Hospital from 2011 to 2014. His training experience spans across West Africa and centers of excellence such as MD Anderson Center in Texas, US, and the Duke University Medical Center, North Carolina, US. He has had numerous clinical practice experience in government institutions and private healthcare groups, including Path Care Lab, now called SynLab, and several hospital groups. Currently, he's a lecturer at the College of Medicine, University of Lagos, and directs the clinical laboratory at Evercare Hospital, Lekki. Dr. Ademola is also a clinical researcher with over 25 published articles in journals of international repute. Welcome, Dr. Ademola Ademola.
Yeah, thank you very much, Dr. Nadim. I'm happy to be here. And first, I'd like to appreciate the leadership of MWAN, Dr. Mrs.
Okay.
Wonderful senior colleague. I met her one-on-one about 2 years ago at a NAT conference. Thanks a lot, Dr. Modukwe Lebute, for opening the discussion. We spent a long time on the call, and I've literally listened through. So I'll try to make this as detailed and concise as much as possible. So my first talk is on use of automation or automated machines and processes for diagnostic tests. And I will be essentially following this outline to first try to discuss what automation is, the role of automation in diagnostic tests, and then we can sort of look at what a prototype automation laboratory looks like, and then we'll discuss the benefits of automation, and then we'll look at why automations can fail, and then of course we can conclude this session. Now, automation comes from the word automatic, and one definition I find interesting is that automation refers to creation and application of technologies to produce and deliver goods and services with minimal human intervention. And that should be underlined, minimal human intervention. Now, it's also defined as the technique of making an apparatus, a process, or a system operate automatically. And so you see that the implementation of automation technologies, techniques, and processes invariably will improve efficiency, reliability, and speed of many tasks that were previously performed by humans. I should say that automation cuts across all fields of human endeavor, and of course in human medicine as well. In human medicine, we're going to be honing down on laboratory automation, which is the bane of or the crux of this discussion. Of course, it also has a lot of role in imaging, medicine, in surgery, information management, Automations can largely be semi-automations, they can be full automations, and they come in varying degrees of hardware and software complexities. Now, in relation to laboratory medicine, automation would be defined as use of laboratory instruments and sample processing equipments to perform clinical laboratory assays with very minimal human involvement. And then it's a process where analytic instruments perform many tests with the least involvement of the analyst. And then the IUPAC, which is the International Union of Pure and Applied Chemistry, says automation has to do with the replacement of human manipulative efforts and facilities in the performance of a given process by mechanical and instrumental devices that are regulated by feedback of information so that an apparatus is self-monitoring or self-adjusting. Okay, yeah, so I would just sort of give a pictorial tour of a laboratory, an automation laboratory in the next couple of slides. Now, I should say that automation can cut across all phases of laboratory testing, which has been alluded to at several points in the presentation. So essentially, we do talk about 3 phases, although some authorities would describe 5 phases of what is called the total testing process or the part of workflow. So essentially the part of workflow, as discussed earlier, pre-analytic to the examination phase or the analytic or intra-analytic, and of course the post-examination or post-analytic phases. Some authorities will talk about the pre-analytic and of course the post-analytics for clear reasons. So examples of automation. Now, this is a Vacutainer system for blood collection. And this is some sort of automation because human effort is much reduced. And then you have the needle probe introduced into the vein. And then you have this negative pressure system that sort of, takes the appropriate amount of blood without human drawing efforts. So you have adequate blood to anticoagulant ratio. And then human manipulative effort is quite reduced. The same system also uses the butterfly needle with the negative pressure system. Now, this point of care for blood glucose is some sort of automation too, because it requires very minimal human interface. And then it's point of care because this can be done at the bedside and it can be done even in home. And then much of these devices can also run on a software in what is called the remote medical monitoring. And so a person owning the device and using the device can be somewhere in Katina, and the reviewing physician through remote monitoring software can review the result real time somewhere else in the US. So that's an example of what automation can do in diagnostic processes. Now, I will just do a further run of an automation laboratory. Now, this is not to market any particular brand of equipment, but just to sort of demonstrate automation in diagnostic testing. Now, this is a chemistry analyzer, and then next to it is another chemistry analyzer. Both of them automation, but with different levels of functionality and capacity. And of course, in terms of the test menu as well, they have differing capacity. So these are examples of automation. Next to that is another analyzer which does chemistries too. And then of course, a different manufacturer. And next to that is a water unit. And these are, examples of automation. This is more of what we call the endoserology bench. And essentially we have a high throughput equipment here, which does a lot of hormones, virtually all hormones, infectives, tumor markers. And then next to that, we have smaller, equipment for a low throughput or medium throughput laboratory that is cartridge based and is able to churn out a lot of hormone assays, infectives as well. And even a lot of infective markers as well. And then even some of the anti-inflammatory or the inflammatory markers as well. Next to this is another automation bench with some manual processes. Of course, a lot of manual hematology process takes place here just before that distilling unit. And then you have this analyzer, which does hemoglobin electrophoresis and protein electrophoresis. And then, of course, different categories of centrifuge, the microhematocrit centrifuge, an automation glycated HbA1c analyzer, and then, of course, an automation ESR system. Just also to run more through automations, typical automations in a laboratory. This is a coagulation analyzer and is able to do a lot of coagulation assays, including factor assays, including D-dimmers, and so many more analyses. The next to this is the hematology analyzer. This is actually a 5-part analyzer. And then next to this is a higher throughput platform, which does 6-part analysis, including retic, and also can pick nucleated red cells. And of course, next to that is a platelet function analyzer. Now, this is what the blood banks look like with automation. Now, this is a blood group automation analyzer. So this instrument essentially can do blood grouping automation, and then it can do cross-match, and then it can do type and screen as well. So you can do a lot of screening for alloantibodies and even autoantibody identifications. And of course, platelet agitator with an incubation system, different blood bank refrigerators, and this is a sub-zero -180 refrigerator. And then next to that, very close to that, is actually a co-centrifuge. Yeah, and then I would also perhaps demonstrate some automation in a blood donor apheresis room. Of course, the platelet agitator, this is actually a blood donor couch with automation. So a lot of it has a lot of reclinable, should I say, potentials and all that. And that's some sort of automation to make ease for patient comfort, which is very, very essential. And of course, the weighing scale. And of course, you have the monitors for pre-donor assessments. And then there is a point of care there, which is the, shall I say, the HemoQ201 for hemoglobin checks prior to donation. And then, of course, to the other side, you have a donor apheresis machine, the Monetics MCS Plus for single donor apheresis. Yeah, so that is what an automation looks like. Now, if you look back in perspective, some of the drivers of automation, includes the demand for tests as a result of population growth and increasing healthcare needs. And of course, that would place a demand on the laboratory. There will be increased workloads. Of course, there has been a lot of improvement in methods, from manual methods to a lot of techniques that could be automated. Of course, shortage of personnel, laboratory personnel, efforts at simplification of work, human errors, as we commonly say, to hear is human and to forgive is divine. As long as there are humans in the system, it's impossible, literally impossible to be error-free. But as much as possible, the essence of your occurrence management system is to pick errors and manage them, to pick errors and create an error prevention and an error management protocol. So the goal is to have little or negligible errors, especially from human interfaces. And of course, the cost of service is also impacted, based on the decision of whether to go manual or to do automations in the clinical laboratory. And of course, with a lot of advances in technology and software capacities, cloud capacities, this is also very significant. There's been very significant growth in the level of automations that we can do. I have machines that are domiciled in Nigeria, but the manufacturer, the OEM, can have control of that machine from somewhere in Germany because of software, because of automation that has been built into this system. So automations has gone really a long way. Now, why automations? One great thing about automations is that because you've reduced the human interface, there's also significant reduction in errors. Number two is that automations also help to address some of the safety concerns. For instance, manually running some assays on the bench might be associated with spills. Well, automations have it cleaner because you have largely robotic systems in the mechanical side running these things, and they are largely far more efficient than human interactions or human intervention in some of those processes. Now, automations also help to reduce the costs, but this is, somewhat relative to the size and volume of the laboratory. Automations, of course, help to improve turnaround time. There is increased productivity, and of course, you can run more tests with automation, and then you can also test in a few centers. So if I have a full spectrum or full complement automation laboratory in Lagos, I can essentially have samples coming in from several areas in Lagos, several hubs in several spokes in different areas, and then I can have these samples, through a very good or carefully arranged logistics program delivered to that automation lab and have a very effective throughput. And that's one thing automation can do for us. Now, while automations operate with fewer instruments, it helps to retain lower operating costs if you have the volumes. You can employ relatively less skilled labor, and in fact, less labor. You can use automation in a paperless environment. So automation thrives better in a paperless environment. If you have a hospital system or a laboratory system that is paperless, where you have a laboratory information system or LIMS, essentially you are going to heavily rely on automation, because many of these automation machines can be interfaced after due interface verifications with your hospital information system or your laboratory information systems, and that also reduces a lot of human errors, which we are very much conversant with in the post-analytic phase of the total testing process. Now, there is also a valuable walk-away time, in order to attend to other more important tasks. So literally, you can program your samples and you can, leave the machine to run the assays, and then you can spend the walk-away time in doing other things. So literally, you can program on chemistry, work to hematology, program hematology, and work to hormones and program hormones, which is virtually impossible to do manually, for the time considerations that you have. Also, automation helps to reduce repetitive injuries from manual labeling processes. And then, of course, automation also helps to manage space. So if you have to deploy human capacity to run some of these assays, you are going to require larger work areas, but with automation, you can require a smaller work area, and you can run tons of experiments, generating patient results, and all of that. Now, why automations again? Of course, more from the quality perspective, there is a lot of reduction in variability, because you literally have a machine, validated machine running most of the experiments, and that causes a lot of reductions or a lot of inter-operator variability in the quality of the results. Of course, a lot of reduction in the error of analysis too. So you can literally cut out human errors in the testing processes. Of course, avoidance of manual associated problems like boredom, like inattention. Automation also helps to improve reproducibility. And that, again, it's one cornerstone of quality in the laboratory. Automations ensure good analytic methods. And then, of course, you can create an effective quality assurance program with automation, because much of these automations are also built with quality control charts, and they are built with some sort of how do I put it? Some sort of restraint. So if you run a QC for a day and the QC doesn't pass, it doesn't allow you to run the patient samples, and that's some sort of check to ensure that whatever the laboratory output is good. Automations also help to achieve a lot of cost effectiveness if you have the volumes. Now, can automations fail to meet expectation? Of course, and these are some thoughts around this. Incomplete understanding of the current environment processes and customer expectations can actually create a mismatch between the level of automation and the customer expectations. Again, loss in flexibility because of fixed processes and limited throughput can be quite, a basis or a rationale for automation. You've seen sometimes government investing in healthcare infrastructure, and they build this so-called 200-bed hospital somewhere in, let's say, somewhere in Kaduna, and of course some challenges, and these are heavily instrumented systems with all categories of instruments, and of course, maintenance is not there. The instruments are done within 6 months or within a year. So without careful understanding of the work environment, the customer expectations, without careful planning, with regards to the expected throughput and all that, automations can actually fail. Unrealistic expectations of the system, as well as poor planning, poor development around automations, and unclear expectations of system functionality. We've also seen this a couple of times where, investors or business owners invest, money into this instrument, and then they are here and there, and then they are expected to churn out money. But again, some gap in understanding of how this instrument works. Some of these are actually created by the vendors, because you have some, vendors who don't clearly understand. They just take the contract, they deploy the instruments, and of course, there is no good training for the end users or the process owners on some of these automations, and then there's still suboptimal services, there's still suboptimal outcomes from the laboratory. Yeah, so some of these things have to be clearly thought out before deployment of automations to ensure that automations do not fail. The other bit is overbuilding and, of course, unnecessary complicated system design. If there is inadequate technical support, and this is quite a challenge in our environment, if there is inadequate technical support, you've brought in this big equipment from the US, and then the technical support is not there. There are no trained personnel or biomedical engineers to fix some of the corrective maintenance issues on that instrument. That automation is likely to fail. So credible and realistic impact analysis never conducted. That's another very important reason why automations can fail. And then sometimes, the leadership is only looking at the cost without looking at maintenance and supply chain issues and even labor required to put these instruments to maximal use. And so these are things that needs to be carefully thought about. Failure to optimize current processes before optimization, and just like the technology experts also say, if you do not have a good operations, if you do not have a good manual operations, or if you've never successfully run a manual operation, it's unlikely you will run a successful automation, because everything is still going to thrive on operational excellence. It's still going to thrive on your operational effectiveness and efficiency. And so automations is bound to fail if operations is not good. Right. Yeah, so never automate a poor process. Now, I just try to simplify what the laboratory automation flow can look like. And essentially, it begins with the patient. Everything we do in healthcare is centered in and around the patient. And that's why patient-centeredness is one of the core elements of quality care, according to the Institute of Medicine. So it's focused on the patient, and like I usually say, it begins with the patient and ends with the patient, and of course the patient-physician relationship. So someone has to identify the patient, someone has to make an order for the test, and then following that is that there has to be collection of a representative sample. There has to be proper identification and labeling of that sample, and that has a lot to do with proper sample sorting and accessioning to the different laboratory benches. Delivery of the sample in a proper storage condition and within time. And then, of course, preparation of the sample for test. Of course, with automation, you are going to load the sample. There's going to be aspiration of the sample, and then automation takes over analysis of the sample. And of course, the results are generated. And then once the results are approved and signed out by the respective or the responsible laboratory physician or delegated person, it becomes a report and literally a legal tender as well. Now, what are some of the downsides of automation? One is that automation can be inefficient if you do not carefully planned it. So there can be a lot of reagent wastage. So why would I buy a heavy throughput analyzer for a 100-bed hospital? There's going to be a lot of reagent wastage because I do not have the volumes to support that level of automation. Okay. Now, also the cost of operations can be high depending on the volumes, and of course maintenance cost as well. And then, of course, job market realities. The more you automate processes, the less the amount of human personnel that you're going to require. For instance, I shadow in a 165-bed facility, but the entire medical records team is virtually 2 full employees, and then some ad hoc staff, which are about 2 or 3 of them. And so you're able to manage an entire hospital information system with just 2 full-time personnel, which is virtually impossible in the same size teaching hospital or federal tertiary facility. But we can achieve this because of automation, because of a very robust hospital information system in place. Okay, now if you begin to think through some of these concerns or problems, you're having increased workloads, you're having some challenges with quality results and reporting of results. You know, for instance, sometimes manual entry or transmission of results is associated with transcription errors. You're having a lot of human errors, a lot of difficulty in controlling processes of failures in test turnaround times, or you need to also include additional assays, you need to streamline processes, or you are really having shortage of trained technologists or technicians, especially in these days of massive exodus of healthcare practitioners. Then automation is worth thinking, you know, and talking about, because automation literally can fix a lot of some of these problems, as I've highlighted. Now, this is some thoughts, you know, that I have. Can we completely eliminate manual processes? I do believe that this is largely, you know, arguable, but I do believe that we can get to that point where we can literally completely eliminate manual processes. I've seen this in some hospitals in the US. I mean, I've been to a full automation laboratory in a 1,000-bed facility, and I mean, I walked through with a hematopathologist, molecular/molecular pathologist friend of mine, and then literally everything in that laboratory unit is fully automation. So you have this pneumatic system where samples collected on the wards are charged into a pneumatic system, and then they are shooted, you know, and then once they are, you know, like shot, they go through a pneumatic system and they get delivered at the laboratory end, which are tons, I mean, miles away from where the patients are and where the samples have been collected. And then in that place, you only need a technician who collects the samples, you know, delivered by the pneumatic system, and then arranges the sample into a carrier, you know, conveyor belt kind of system. And then that's the only human interface required. Every other thing, from sample sorting, sample accession into the different hematology area, chemistry area, GCMS area, microbiology, every other thing is fully automation with very complex conveyor belt systems, heavy throughput analyzers, and then even waste management, everything is full automations, you know, completely ultra and true. The only interface for human there is somebody to take the samples from this, you know, pneumatic system and then to arrange them, and then the system takes over. And then at the other end, in the pathologist's office, is just sitting there looking at results and signing out results. And that's, you know, so I do believe that full automation is possible. The other thing I would emphasize as a concluding slide is to say that we need to also think about, you know, appropriate automation, and there has to be that balance between manual processes of full automation, and this is largely impacted by a lot of variables as discussed. And so I do advocate for appropriate automation, because healthcare has to be, or healthcare systems has to be effective, getting the right outcomes, and it has to be done in an efficient way, such that we can get the best outcomes. Yeah, so this concludes the first presentation, and I don't know if to take questions at this time, or we can actually move to the next topic.
Please move to the next topic, sir. Move to the next topic. Thank you.
Thank you, ma'am.
Okay, we are going to hold on with our questions and move on to the next. We are going to move on to the next lecture and take all Dr. Ademola Ademoyi's questions together. So we move on to the next lecture immediately.
Yeah, so I'm trying to load the second slide. A minute, please. Okay, thanks. I do believe my second slide is up. Please confirm to me. I need some feedback.
Yes, it is. We are seeing it clearly.
Thank you, ma'am. So I'm looking at quality control in diagnostic investigations, and then I'll come down to sample transport to a reference laboratory or a testing laboratory. So objectives of this talk is to just look at what is quality control and what's the relationship to the overall quality management system. And then we look at quality control across the different sort of examinations that we do in the laboratory. And then I would conclude this with some review of the pre-analytic requirements or pre-analytic process control efforts that we put in place to ensure appropriate outcomes from the laboratory. Now, so much of the time I might be using the word QC as often used in laboratory parlance. Now, QC refers to, or quality control refers to examining control materials of known substances along with patient samples to monitor accuracy and precision of the analytic process. And I think I probably would do some explanations around this. Now, quality means different things to different persons. So you talking to the patient and you're asking, oh, so what's your idea of quality? So to that patient, quality means heal me. Some patients will tell me, do not harm me. Some patients would, tell you, be nice to me. And that's their perspective of quality. And so you see a lot of time in healthcare, we tend to focus a lot of energy on clinical excellence, having the right outcomes. And we tend to focus a lot on the physical comfort of the patient. And then, of course, a lot of effort on the processes to ensure that everything is tied up. Now, to the clinical side, a clinician asking or ordering for a test from the laboratory is quite interested in the laboratory generating accurate, reliable, and timely results. And of course, you ask yourself, what's the essence of giving out a potassium of 7.3 when the patient is already dead from some cardiac complications from hyperkalemia? So that result has to be accurate, it has to be reliable, and it has to be timely. And of course, from the laboratory perspective, and as laboratorians, we tend to look at quality in terms of having the right test done on the right patient and having that right result within the right time, and of course at the right cost. Yeah, so quality control checks or quality control materials, they are substances of known concentration that we run along with the patient samples, and we use that to often daily to check the accuracy and precision of the analytic phase. So it's often referred to as internal control because we can also have the external control, external quality control materials. It's a set of procedures undertaken by the laboratory staff to ensure continuous and immediate monitoring of laboratory work in order to decide. And I put that in bold, to emphasize the essence is to be able to decide whether the results are reliable enough to be released. So if the controls have not passed, then that result cannot be released, and that's good quality or good laboratory practice. So now the bigger entity under which you have the quality control is the quality assurance program for the laboratory, or quality assurance in diagnostic testing. And that refers to coordinated efforts to achieve good quality results, or all the planned and systemic actions necessary to provide adequate confidence that the product and services of the lab meet the customer expectations. And of course, both the internal customers and the external customers, the referring physicians, the patients, and other healthcare professionals that require the results. Now, of course, I've tried to talk around this. That quality to us means right result at the right time on the right specimen, because you can have the right result on the wrong specimen, and that's zero quality. You can have the right result on the wrong patient, and that's just like a surgeon taking out the wrong organ. That's still poor quality. And then if you also offer this service at the wrong price, of course, it's also poor quality, because that's going to impact on the overall outcome of healthcare. Now, the goal of QC, which is the focus, is to detect errors and to prevent them before the patient's results are reported. So underline errors to detect errors, and then underline the error correction report in what we call the occurrence management process. Now, quality control is used to measure, I mean, a lot of repetitions around here, but again, that's the crux of the discussion. It's used to measure, it's used to monitor accuracy and precision of the assay. Now, when we sort of look at test methodologies, there are some variables that we deeply review before we can sort of validate a particular assay for routine use or for routine clinical purposes. One of those is that we're looking at what's the diagnostic reliability of this particular assay method. You know, and we are comparing that to some reference methodology. Of course, they are all called reference methods. And so we are looking at the diagnostic accuracy, the diagnostic sensitivity, the diagnostic specificity of this particular assay in question, and of course, the accuracy and precision. Now, accuracy, we are looking at what the closeness of the measured result to the true value of that result. So for instance, the true result of a potassium is 5, and then your own test methodology is measuring 3.0. That's a major bias or inaccuracy. So biases are inaccuracies. So we look at test methodologies with very good accuracy, and then we usually do correlation checks in the laboratory. In fact, before an analyzer is put to use, there has to be a correlation analysis, or what we call method verification. We need to check what the manufacturer has said this machine has the capacity to do, and then we need to verify what this manufacturer is trying to tell us the machine can do by comparing, you know, what we are getting with the machine to a reference method, and we do a correlation analysis to see how accurate that analyzer or that test methodology is. Precision has to do with reproducibility. You know, it has to do with repeatability of a test. And then what we usually do around that is that we would do a number of runs, either with some variability of the operator or the same operator. And then we do a lot of runs, and then we check, you know, for how precise the analyzer is by looking at the mean and then the standard deviation of that particular set of runs. And so that can give us an idea of how precise that assay method is. So if you look at the first target, the points represent individual tests, the yellow circles represent individual tests, and then they are the center, you know, which means that the measured value is close to the true value, and that's an accurate method. And then all the test runs are also concentrated in the same area, which shows that this test method is precise. So what we look at in verifying and deploying that analyzer or that test methodology, whether it's manual or its automation, is to ensure that that process is accurate and precise, because that's going to likely impact on the quality of patient result. Now look at the next target. You have at the center, the clusters of runs. The individual tests are far away from the center. So this test method is not accurate, because the results that you are getting is not close to the true value that you should get, but they are very precise. They are all concentrated. So you can run it 100 times. It's going to give you almost the same result, but it's not accurate because it's far from the true value, which is the target at the center. Now you look at this other one is imprecise. So you have a value very close to the center. You have another value very far away from the center. And so you run a hemoglobin check, and the hemoglobin is, you run it now, it's it's 12 grams, you run it again, the same patient or the same sample perhaps, and it's 16 grams per DL, and then you run it again and it's 14 grams per DL. That's a very imprecise method, and that has a very weight implication on patient results. So an accurate result is precise but not biased. Okay. Now, QCs as determined in the laboratory will also depend on the type of test method. So generally, the examination phases can be quantitative. You know, for instance, sodium, you are getting a value of 140 milliequivalent per liter. That's a quantitative result. As against you running a RDT pregnancy strip, and then it's only going to tell you, oh, this pregnancy test, urine pregnancy test is positive or negative, which is qualitative, or as against semi-quantitative, where you request for a blood film for malaria parasite, and then they've done the thick film and then the thin film, and then it's reported as, oh, this is malaria blood film for morphology, and then that malaria parasite is reported as 2+, you know, as against possibility of 4 pluses or 0 in the first instance. So the QC process, the control process also differs based on the type of methodology that we are deploying or that is being used for a particular test process. Now, for some, you know, quantitative process, I think I should skip this slide. Yeah, we use what is called control materials. I think I tried to describe this before, and that these control materials have to be run at the time of patient runs when you want to do routine runs. And then it's used to validate for that particular experiment you are doing, is used to validate that process. And it's used to validate the reliability of that particular process. Typically, you run your controls after you've calibrated the instruments, and then, of course, your controls are run periodically during the test. And oftentimes in the laboratory, we do much of daily controls, which we call DQCs. But sometimes some test methods require more frequent runs. These are less stable, you know. So there are recommendations, international recommendations on the runs and how you should program your runs into each routine runs for your lab needs or laboratory use. I should also talk about calibrators, because you can't run controls without calibrators. Now, calibrators help to sort of align the set points on that analyzer with the true value. You know, so calibrators are substances of known concentrations in varying concentrations, and then they are used to set the points, the measuring point on that particular analyzer. You know, so when you calibrate, then you can run your control. So calibrators do not have to be, you know, like, they don't typically have the same milieu as the patient samples, but typically the control materials that we use, they have the same milieu, because you are trying to simulate the patient run, and then you have substance of known concentration with known targets. So controls come with targets. So you have, and typically we have different levels of control for most of the laboratory runs, and we usually encourage using at least 2 levels of control. Usually we talk about level 1, level 2, and level 3. That's the high, the normal, and the low, because you also have to determine, you know, just trying to not go too deep on, to determine the linearity of some of these analyzers. And then if you are running your controls, the control should be able to cover the entire spectrum of possible patient results. And so you are likely to have patients with low sodium, you are likely to have patients with high sodium results. You should have controls that can verify that, oh, your laboratory can correctly pick low sodium results, and your laboratory can correctly pick high sodium results. Okay, and sometimes too, we sort of also walk away from first-party control. So this manufacturer has given us, or we've procured this particular instrument, and then, you know, that comes with calibrators. Calibrators are almost always gotten from the equipment manufacturers, and that's why we don't try to do or reset the calibration. We just align with the manufacturer's recommendations. But the controls, sometimes, because they always want these controls to pass, they have very wide standard deviation, and that's just to allow you, get your QCs to pass almost always, and then to get their equipments in use or their reagents in use, and of course they want to make more money. And so sometimes, when we are not to, we also deploy the use of third-party controls, which have more strict, and of course that's better for laboratory performance. So that there's a lot of thought that also go into selection of control materials for testing processes. It's important to adhere to the manufacturer instructions, and it's important to keep the amount of the same lot number, and it's important to store correctly according to the manufacturer instructions. Now, there are some sort of important steps especially for quantitative QC procedures. One is that you have to establish policies. It all begins with clinical governance or the laboratory management, And so that defines your policies, defines what your procedures will look like. Of course, you have to assign responsibilities, and then you have to train staff, and I quite appreciate when Dr. Modipe was describing having to train some of the bench scientists with some proficiency gaps in making good quality peripheral blood films. We see a lot of this in practice, and we can only resolve this with a lot of in-service training. So it's important to have a lot of in-service training, and training competency records have to be developed, and people have to be signed off, for the respective benches. Because for those that operate based on ISO levels, this is clearly well understood, and these are checks for quality assessment. Also, it's important to have high quality controls, and like I discussed, where necessary, you might need to get third-party controls. It's important to establish control ranges. So these controls don't just run in isolation, they come with ranges. It's important to also develop graphs to plot the control values. So you get your control values, you also need to see the pattern, the trend, so that you can pick biases, and then you can respond effectively. So you need to monitor these control values. I just occurred to me that I didn't put, I should have demonstrated what a Levi-Jennings chart looks like. This actually didn't start in healthcare. And so some of these quantitative QC processes have been in other industries, and then we of course adapted it to healthcare. You hear about Six Sigma and some other quality control in manufacturing and some other industries as well. Yeah, so the Levi-Jennings chart is largely what we use in the laboratory, and then we have a set of decision rules that helps us to accept or reject the control run. So these decision rules are largely spelled out by the Westgard, and that's why we usually talk about the Westgard rules as well. So you need to monitor your control values, and you need to develop a procedure for corrective actions, and then you need to record. Like we say in laboratory balance, if it's not documented, it's not done. So everything has to be documented, because the auditors will not just witness your procedures, they are going to also look at your documentations, because if it's not documented, it's not done. Okay, now for qualitative quality controls, these are growth, no growth kind of results, positive, negative, reactive, non-reactive kind of results, and I try to demonstrate some of them: growth, no growth. Now semi-quantitative, like I described, malaria is a very good example, and you can have no malaria parasite seen, or 1+ or 2+ or 3+ based on the number of parastemia you see per field. Now, I'll just also throw some concepts that we should think about in quality control, and one is sample management. Like I often say, the quality of your result is as good as the quality of the sample, and so it all begins with the sample, and that's why I would usually employ every organization to focus a lot on pre-analytic requirement description or documentation, so that this is accessible to the pre-analytic team. And that can include the nurses on the ward who can collect the samples, the physicians needs to know the sample collection protocol. It can even include the technicians in the sample collection of phlebotomy rooms, who needs to know also how to collect the samples. So a lot of focus has to be given to sample management protocols. Of course, a lot has to be given to staff competencies. I've recent time had story about a staff who didn't know how to collect a COVID PCR sample, and that's likely because of training gaps. Of course, equipment maintenance protocols and both preventive maintenance, which cuts across daily routines that you should do, weekly maintenance schedules, monthly, and of course, annual preventive maintenances, which are often 6 monthly or annual, depending on protocols per equipment manufacturer. And of course, you must have a system around your corrective maintenances as well. So the equipment has broken down. How do you resolve this? How do you go about this? What have you put in place? Do you have in-house engineers? Do you have the service engineers close by to resolve some of these issues? Because this likely has an impact on your performance as a laboratory, on the quality of your equipment downtimes, a reflection of your laboratory performance as well. Of course, your quality materials, you have to have a good supply chain. I've seen laboratories that run assays without quality control materials. And like one of my trainers would always say that every experiment in medicine without control is invalid. But again, because of some gaps in regulation, as it were, in the country, some gaps in surveillance, some gaps in monitoring and enforcement activities. You see a lot of laboratories churning out results without quality control, without QC. They do not QC the experiments, they do not QC the operators. There are no measures to contain indeterminate errors. And so you see a lot of spurious results out there that has heavy impact on patient results. And I can give you tons and tons of examples around this. Of course, your record keeping I mentioned. Now, this is like some sort of example of a control check for a qualitative process. So, and this has to do with blood banking. So you've issued out, or you want to issue out a plasma component, like a physician has requested for FFP for a DIC case. And then it's not the best. I mean, plasma is yellow or straw colored, and then you are having plasma that is a bit contaminated with red cell. What's going to be your decision as to quality, as to what do you issue out? Can you issue out? So this was developed by Mayo Clinic Laboratory, and then it's some sort of standardized visual inspection tool for plasma components. And so you can look at the plasma and compare with this as a sort of control check and determine whether this is acceptable to be released or is unacceptable to be released. So this is an example of how we use QC check in blood banking. Now, if QC is out of control, what do? Stop the testing. It's as simple as that. So your controls have not passed, stop the testing. What happens next? Troubleshoot. And so there's a lot that goes into troubleshooting, and then that requires a lot of technical experience on the bench to be able to resolve. And oftentimes, or sometimes, you have to bring in a more experienced person or bring in the service engineers to resolve issues. And of course, after your corrective maintenance, you need to do your calibration again, and then you run your controls. If the controls pass, then that means your troubleshooting has been effective, and then you can then deploy your analyzer to routine clinical use again. So you need to identify the problem, and you need to correct the problem, and then you need to repeat tests on the patient samples and controls after correction. Do not report patient results until the problem is resolved and the controls indicate proper performance on that particular assay. So if sodium is passing and bicarbonate is not passing, you can only report sodium, you cannot report bicarbonate. And so that's why you have to have control materials for every type of, for every specific test on your menu. Although they are what we call multi-control serras. So there are some serras that have multi-control abilities, but oftentimes you have to have specific control to specific assays. Now, I leave you with this final slides. In trying to establish a good QC program, some of the steps, you have to have a well-written policy and procedure. You need to train your staff, and I can tell you in this kind of environment, there's need for a lot of in-service training. And so this has to be heavily impacted by management direction, because much of what you see around here is that there's a lot of gaps in pre-service training. I've seen bench personnel who have no idea of quality management system. And so what assays are they going to be resulting? What results are they going to be churning out from that laboratory? So a lot of in-service training has to be incorporated to assure results of that laboratory. documentation, of course, and then you have to have a documented QC review process. You have to have your QC data, the interventions, everything has to be documented, because when an auditor comes, he wants to ensure that you have these processes in place before you can get a plus. Now, pre-analytic, we've talked a lot on this. I should emphasize that about 70% of errors, or as most other references will say, about 2/3 of laboratory errors are pre-analytic. And that's why I often say that the quality of your result is only as good as the quality of the specimen. The clinician is not giving me a very good quality sample. There's a limit to what I can do on that sample. But it's also a responsibility to ensure that that clinician knows what to collect, knows the appropriate sample bottle, and can do that collection so that I can have a good quality sample, a representative sample, to be able to generate a good result for patient care. Now, some of these considerations are important to sample transport. And this is where a lot of errors come in under pre-analytic. Sample transport to a reference laboratory or a testing laboratory. One, you need to choose the appropriate bottle, and that is determined by the test methodology as well. So you want to do karyotyping or cytogenetics, it's the sample characteristic or requirement is different from when you just want to run basic histology on a sample, where you need to have a formalin fixed sample. So it has to be a representative sample. The sample collection technique is very important. You want to collect a calcium sample, what's the tourniquet effect, and what the delays or a lot of manipulations in collection of some of these samples will affect the target or will affect the results. What should be the timing? Early morning samples that's different from natural specimens that need to be collected. So we need to, the clinician needs to have a very good understanding of, or the phlebotomist has to have a very good understanding of what the nature of the sample collection should be, and what the timing should be. Of course, sample packaging, the way you package a COVID sample is not the same way you're going to package so the concept of packaging to reduce spillage and to ensure containment is very, very important when you are sending to a reference laboratory. What much of packaging should you do? Paraffin use on the primary tube, triple packaging and things like that. Decisions have to be taken, and this has to be protocolized for each test methodology. Now, transport conditions are also very important. Some samples can be transported at room temperature. Some other samples require refrigeration. Some other samples require freezing. And so you need to get dry ice for shipment of some of those samples. What's the sample viability or storage time? So you want to do an immunophenotyping. A sample for immunophenotyping arriving 7 days post-collection is literally invalid, because you have a lot of cell death already, and then you are going to have literally no cell left for the assay in question. So sample viability has to be put in perspective in relation to the transport, that sample delivery to or dispatch to the reference laboratory. And of course, again, you have to look at the regulatory requirements. What do the regulatory authorities require? If I'm shipping a DAO specimen to the US, there are regulatory requirements, there are approvals that has to be gotten, there are IATA certifications that has to be in place. And so the summary of this is that you need to confirm the pre-analytic requirements with the testing laboratories and of course with the regulatory authorities. And then I will say this on a final note, that laboratory management must ensure quality policy and system and ensure quality control of essential laboratory processes with audits, and of course, including external audits, which is still very low key in our system, and that as much as possible. That's my final slide, and I want to say a big thank you for the audience.
Thank you.
Thank you very much, Dr. Ademola Adewon. You just gave us 2 quality lectures. The first lecture you gave us was on automation in the lab, and the second on sample collection. And then we are opening the room now for questions. If anybody that has questions, you can go ahead and ask your question, please. And I'm going to check into the chat box and look for those who have asked their questions in the chat box. Thank you very much. If there are any questions, let me check the chat box for questions. Okay, Dr. Lillian says very interesting and helpful presentation. Thank you, sir. Okay.
A question.
Okay, we don't have any questions from her.
Hello.
Thank you very much,
Good
Dr.
afternoon.
Demola, for this beautiful
Thank you. Good
presentation.
afternoon.
So we have come to the end of the
I have a
CME
question.
on medical lab. Dr. Kemi, do you have something to say?
Yes, so thank you for the presentation,
Okay,
Dr.
go ahead.
Ademola. Yeah, please, can you hear me?
Sure.
Can you hear me?
Oh, go ahead with your question.
Yeah, please, I would just want to ask, thank you, that was an excellent presentation. Please, I want to ask, for an automated laboratory, who are those in charge of the getting up the standard operating procedure, the policy of the instrument, the procedures and the policies guiding the instrument? Who is supposed to get it? Is it the installer or the laboratory manager? Thank you.
Yeah, thanks for the question. Now, for the quality manual that defines the policy and everything quality-wise for the laboratory, it's the responsibility of the laboratory leadership or the laboratory management. And the laboratory management, of course, will include the clinical directors, would include the pathologists in the laboratory. We also have quality managers or quality assurance managers for the laboratory who are just quality experts. And of course, it will also include the lead bench scientists. But for technical SOPs or technical processes, what we advocate is that those processes has to be developed by the process users. So the person running the hematology bench has to develop the protocol for the hematology bench. The person running blood film has to develop the protocol for the blood film is going to be making. And so these protocols are written by persons, and then the protocols have to be reviewed and approved by the laboratory leadership or the quality assurance manager. The import is that the pathologist has to be involved in every aspect of this, because the pathologist is clinical oriented, and that pathologist would ensure clinical effectiveness of the laboratory solutions or the laboratory outcomes. Yeah, so for instance, according to ISO, no instruments can be put to routine use without a pathologist approval of that instrument, because that instrument is deployed for the sake of the clinical use, for the sake of patient needs. And then the person that can tell that, look, this instrument is fit for purpose and is fit for this patient population is a trained laboratory physician who can marry both the clinical understanding with the laboratory, with both the clinical understanding with the laboratory understanding of the functionality of the equipment, and say, yes, this particular analyzer is fit for routine patient use. And then once it's sort of approved or validated, then it can be deployed to routine use. I hope that answer is helpful.
Yes, sir, but I would want to know, for the installment of the equipment, so who does should I now say the calibration, the validation? This is an equipment somebody is bringing in, you have never used before, they installed it. So who is supposed to be responsible for the manual, something like that? Thank you.
Yeah, so for a new instrument, ideally, that doesn't often happen, but ideally, before you put an instrument to use, you should validate or verify the instrument. And that verification exercise usually requires a plan. So there's what we call the verification plan or the validation plan. So you plan out, okay, yeah. So typically you give this analyzer with the reagents, consumables, and all that to the bench personnel and say, look, I need you to run a validation on this instrument. And of course, in laboratory parlance, we understand what that means. So we need to do a correlation analysis and we need to do a precision study. Now we do that, and then the bench person generates the data, and then we review the data. So in a robust system where you have a dedicated quality assurance manager, he sits down to review the data, he analyzes the data, and then presents the results of the analysis to the pathologist, who also reviews and looks at a lot of checks on that review and checks that this instrument is fit for patient use before that instrument is deployed, for use. Now, installation typically is done by the equipment manufacturer or a trained service engineer. So they will come and install and they will calibrate. And then after they install, and calibrate the analyzer, they hand the instrument to the bench users, to the process owners, and then we take over from there. And then we also, of course, they have to train us on how to use that instrument. The OEM always has to train, and you have to sign that evidence of training that, oh yeah, we have these instruments and we've been trained, because you can never use an equipment like the OEM. The OEM has to tell you, look, this is what this instrument is, this is the capacity, and exposes you to everything, both hardware and software about that instrument, so that you can put that instrument to maximal use. And of course, the bench personnel, typically the laboratory technologists or medical laboratory scientists, would be involved in routine use of the analyzer from time to time.
Thank you, sir.
Sure. You are muted, Dr. Nodim.
Are there any more questions? Any other hands up?
Yes, ma'am.
Okay, Dr. Lillian Ekwem.
Yes, good afternoon. I actually asked the question in the chat box, but I think it wasn't read out. Sir, thank you very much for this very, very helpful and insightful presentation. I have a question that relates to errors in automated machines. Recently, I don't know how it can be corrected, but I recently had a case of a baby that was very severely jaundiced, but when the result came, it was in microgram per liter, I think, and it was very small. The range was the amount was so small that we just on our own decided to put the baby under for therapy. But we discovered that with subsequent results, the value was reducing, and yet the jaundice was clinically more. So I was talking to them that I thought they meant to say milligram per dl rather than micromoles per liter. I don't know if it's possible for a machine to come, because it's an automated machine. Is it possible that when it is done and calibrated, that the units could be wrong? Is it a manufacturer problem, or is it the laboratory scientist problem? Or I really don't know. I was trying to discuss with them. They were insisting that they were right, and yet the baby was very, very jaundiced. And the result they were giving us in micromoles per liter was very small.
Right. Yeah, I mean, there could be a lot of problems around there, and this is part of where we come up with what is called the root cause analysis, so that we can identify the problem and do a CAPA, corrective action, preventive action. So certainly there are some quality gaps, because like I usually tell clinicians, first and foremost, you're a clinician, and first and foremost, we do not treat patient results, we treat patients. And that's one essence of having a laboratory physician in that laboratory space, because he would ensure clinical effectiveness of that laboratory outcome. The bench personnel typically are trained on equipment use, they are trained on equipment methodologies, they are trained on quality management system, but they are not clinical oriented persons. So even when you are saying, look, I'm seeing worsening jaundice, they can't appreciate it, and it's not their role to appreciate it.
They were insisting, it was almost like they were getting angry.
Yeah, that's why in high complexities, moderate to high complexity laboratories in the US, by law, that lab cannot run without a pathologist leadership. But that's another discussion. Now, the bit I can see from that scenario is that before you, as part of validation in what we call interface verification, that analyzer, we need to have understood the analyzer and know what's the unit of measurement of the analyzer.
Exactly. Yes.
And if you understand that that's the unit, let's say that analyzer is actually programmed to result in milligram per dl, not micromole per liter, and then there's still discordance with the clinical status of the patient, then it's important to now begin to ask questions. Were quality controls run? Did they pass? And probably if there are records, one is to look at the performance of that analyzer over time, and then begin to try and figure out, could there be some interference with the assays, negative or positive interference with the assays, and to try and do a root cause and get to the root. of that analysis. But of course, as a clinician, you have to rely more on your clinical skills. What you are seeing in the patient is more important than what the laboratory result is, because at the end of the day, you probably might not be able to hold the laboratory responsible, in a sense, in a sense. And what I mean in a sense is that a result approved by a result approved directly from the bench without clinical interpretation is probably not a legal tender yet, except, so it's difficult. So it's always better to trust one's clinical acumen.
Yes, that's what we did, because in case of litigation, we would not have had a backing.
Yeah, and of course there are grounds for second and third opinions and for interlab comparison. So these are also some things that could be done to try and resolve some of these scenarios.
All right. Thank you, sir. Thank you.
Thank you.
We want to thank Dr. Derry for this brilliant presentations. You have brought a lot of new insights to our understanding as clinicians. And I believe that from time to time, people will want to reach out to you for clarification on some of these issues. And I want to keep reminding our distinguished audience that the application of all that we have learned today on laboratory medicine procedures is not just in the treatment of patients, even in policy making. If you don't have a good understanding, you may approve policies that are hazardous to patients' care because you didn't have this basic understanding. People will come because of agitation, different pressure groups, different professional associations, all seeking autonomy. They will come and demand, and it will look as if, oh, the doctor is trying to be everywhere. But there is a reason why these processes are there, and that's why the industrialized countries don't have this challenge. But in our own country, Nigeria, almost everything goes. And so it's like majority carry the votes, whether it is right or wrong. So it's important that our policymakers have this information, and it will also guide policy. And it's also important for research purposes. Many of us feel that we are limited when we don't have certain specialists in our environment. But with the possibility of transporting samples and transport media from one part of the country to another, and even to other countries, you now make your practice to be standardized. It's a way of helping with quality control too, by sending your samples to reference laboratories. And we must know how to ensure that this is done. Some of us just feel that if you are not physically present in a place, you cannot access care. Right now in the United Kingdom, COVID test is done as a self-test. I do not know how many of us are aware. It's done as a self-test. You pay online, apply for it, it's posted to you, and then you collect the sample. You read the instruction, and then you collect the sample, and then you put it in a sealed container, put it first in the specimen container, then put it in a sealed bag, and then you put it in an envelope, and then just take it to the royal mailbox and post, and it gets to the laboratory, and before you know it, your result is sent to you via email. If such things can happen, then why should we say, oh, unless you start sending your patient all the way to Sokoto, or all the way to Abuja from Bonyi, or from Osun State, and so on and all that. These are mechanisms that we can use to make the care of our patients easier, rather than sending your ill patient all over the place. The person may not even survive the journey. You can send a sample, and that is the importance of having transport mechanisms available. Let the cure of the illness not be worse than the illness itself. I believe I'm right, Doctor.
Thank you very much, ma'am, for your comment. And we have come to the end of this session now. We had 5 lectures, 5 CMEs. The first lecture was taken by Dr. Elebute. She talked about abnormal blood count and blood smears. Prof. Oboro talk about gram staining, urinalysis, urine and stool microscopy. Dr. Augustina Semoro talked about PCV and blood smears. Why Dr. Adewale told us about automated machines for diagnostic tests and quality control in diagnostic investigation. You will agree with me that that was a very rich lineup of presentations and lectures. And please, if you are not joined the Telegram group, check the chat box now and join the Telegram group so that you are going to get the slides for this presentation. And for those who asked the first presenter question, Dr. Elebute, I'm going to get your questions across to her and I will post it on the Telegram group. Thank you very much for coming to this lecture. And we have come to the end of this and we are going to close the meeting now.
We can have a Muslim.
Do you have any closing remark to make?
I have made those closing remarks, but we like a Muslim to pray since a Christian prayed at the beginning. So I hope we have some of our Muslim members in the audience. We would like them to, a Muslim volunteer to give us a closing prayer. And you've thanked everyone, but you've not thanked yourself. So we thank you, Dr. Nadim, for brilliant moderation of this CME. God bless you.
Thank you very much, everyone. We come to the
Can we
end
have
of
a
the
Muslim
Put
prayer?
your videos on, let's see you. Put your videos on, let's see you. Let's take a snapshot. Put your video, let's see you the way you are now. Don't be
please,
shy.
can we have a Muslim volunteer? Raise your hand if you're a Muslim to give us a closing prayer.
Hello.
Thank God. Our M1 ambassador, Dr. Halima Nyanko, please, you give us a closing prayer.
I see you. Welcome. Okay. Thank you all very much. Thank you. So that's at the end of the meeting.
And then
Dr.
Halima Nyanko is giving us the closing prayer.
Okay.
Yes, Dr. Halima, please. Dr. Nyanko, please, can you give us the closing prayer? She's our M1 ambassador. She's not unmuting. Oh dear. Okay. Maybe she stepped out. So okay, any other person can give us the closing prayer since we don't.
Okay, can we pray? We said a Christian prayed before, since there is no volunteer. We are grateful for this opportunity, Heavenly Father, for us to come together and learn. We have learned and unlearned.
Sorry, we have a Muslim, Dr. Hawa. Dr. Hawa has raised her hand. Dr. Hawa, please go ahead.
Okay, pray for us.
Thank you very much. Good afternoon.
Okay, very good.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين. الرحمن الرحيم. مالك يوم الدين. إياك نعبد وإياك نستعين. اهدنا الصراط المستقيم. صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين. We thank Almighty God for this opportunity for the CME. We thank our president and our presenters and the anchors. We pray for Allah's guidance and blessings in the implementation of the knowledge that we have gained. Amen. Thank you very much.
Bye-bye. See you in Ibadan.
Amen.
Dr. Tolori, number 23. 30 more days.
Bye, ma.
Bye-bye.
Bye-bye, ma.
Bye.
Thank you, Dr. Secretary.
Thank you.
Bye.
Bye.
President. Thank you.
Bye,
Bye-bye.
Dr. Kwe.
Bye-bye, ma.
Bye-bye.
Thank you. God bless you. God bless you in Jesus' name.
Amen.
Thank you very much.
Dr. Agolo, good to see you. Thank you for joining us.
Thank you, ma'am.
All right. End meeting.